Good morning, ladies and gentlemen. Thank you so much for joining us at the South Carolina Legislative Black Caucus Minority Health Summit. If you can please take your seats, we would appreciate it. We're going to go ahead and get started now. First of all, how's everybody doing today? Good, good. Yeah, this is a health summit, so we need to get some energy. Yes. Do we need to do a little stretch and work out? I got my good dress on, but I'll work out with you this morning. Thank you guys so much for joining us. I'm Trey Taylor. I work with the caucus on public relations, media, and marketing, and it is I'm so glad to be here. And thank you guys for kicking off your Memorial Day weekend at a health summit. Remember all of this at the cookout this weekend, okay? So listen, we've got a great day planned for you. Amazing food from the Brooklyn Banquet and Conference Center. Anybody been to the Brooklyn Banquet and Conference Center before for their great buffet? Well, we've got some great healthy food. Devin and I went back and forth about mac and cheese or rice. I thought mac and cheese. He's like, mac and cheese at a health summit. I said, maybe they won't do so much cheese. I didn't win. We have not only have some great speakers for you and presentations, we've got some prizes. Does anybody like prizes? First of all, we want to thank all of our sponsors, Healthy Blue, Select Health, who also provided some of our bags. Grail is also a sponsor. Dr. Moses Yuda, I think I got it right. Did I say it right? Thank you so much. He's a sponsor also. DHEC also provided some great stuff for our swag bags. The South Carolina Commission for Minority Affairs, Brent Brown, he donated some swag, and I want to tell you about a great event they have coming up that will benefit scholarships for young people. We'll talk about that later. Also, the Columbia Chamber of Commerce donated some stuff. PNB Promotional provided our clear bags, which are always great because you need them, you know, for concerts and other events. Also, Sabriti Hair and Skin Products donated some door prizes, and the Brooklyn Banquet and Conference Center. We've got a couple of gift certificates for you to come back and enjoy macaroni and cheese and fried chicken at the Brooklyn Banquet and Conference Center. So we want to thank all of our sponsors and all of those businesses that provided donations. Also, Restore Chiropractic Family Wellness, Dr. Ivory and Marsha Thigpen also provided a donation for a gift, and the person that's going to come up now to bring the welcome has also donated a gift. Please welcome State Representative Heather Bauer.
Thank you, Trey, and good morning. Yes, so my gift certificate is for a 3-month membership at my gym, Warrior Fitness. So come work out with me. We do kickboxing, low-impact workouts, karate, so we have a little bit of everything. But first, good morning and welcome to the South Carolina Legislative Black Caucus 2023 Minority Health Summit. My name is, again, Heather Bauer, and I represent House District 75, which is Southeast Columbia. And I'm a very proud member and participant of the South Carolina Legislative Black Caucus. I am pleased to welcome you all to this important event. This year is the 4th year that the caucus has hosted this summit, which is dedicated to providing vital information regarding health issues affecting minority communities. Simply put, our goal is to educate citizens of South Carolina, and particularly minorities, on critical health issues and topics, hoping that it'll affect or encourage change in their lives, communities, and the state. The topics for this year's summit are especially important, focusing on wellness and self-care, addressing disproportionate health disparities in minority communities, cardiovascular issues and diseases such as heart disease, stroke, hypertension, and lessons learned from the COVID-19 pandemic. We have a diverse group of speakers who will share valuable insights and expertise on these topics, and there will be plenty of opportunities to participate and engage throughout the event. And whether you're joining us in person or virtually, we appreciate your presence and participation. And we hope that you will take something valuable away from this summit and share it with others in your community. Thank you again for being here, and we look forward to a very productive day. Thank you.
Thank you, Heather, so much. Heather is a prime example of the diversity at the South Carolina Legislative Black Caucus. We are just want to engage members, regardless of their gender or ethnicity or party, to provide support and advocacy for the Black and brown people of South Carolina. So thank you again, Heather. Our first panel is about wellness, self-care, mental, physical, and nutritional health. Before we bring up our participants, we do want to say hello to our online audience. If anyone in our online audience does have a question or a comment, please let us know. David Pendergrass and his group will let us know, and we will address your comment. First, I want to give away a prize. Does anybody like prizes? You said you like prizes, so we're going to give, Regina's in the back. She's walking in and she's throwing her hands in the air, waving them around. All right, so we just put everyone's name in a virtual hat, and we're just going to throw out somebody's name. Our first prize, now let me just say this. All of the prizes not going to be this easy. We're going to give you some trivia, too. And you can phone a friend. You can use your phones or whatever. Okay. Our first one is Sandra Bolton. Sandra. David, do we have some good walking music? Maybe not. Sandra, congratulations, and thank you for joining us. All right. Y'all give it up for Sandra. All right, so let's get to why we are here. Please welcome again Representative Heather Bauer, District 75, Richland County, and co-owner of Warrior Fitness Gym. She was our first panelist, and if we can get the mics to our panelists for our panel on wellness, self-care, mental, physical, and nutritional health. Thank you, Heather. This is her gift certificate for her gym. 3 months. This is good. Also, Dr. Robert Banks, South Carolina Department of Mental Health, Acting State Director. Y'all can clap for Dr. Banks. And Dr. Holly Williams is President of the South Carolina Chiropractic Association. Thank you so much for joining us. All right, David is going to get our panelists mic'd up. We're going to ask some questions and then give you an opportunity to ask some questions. Thank you all so much for joining us today. Let me ask this first question to all of our panelists, and we will start with you, Dr. Williams. What are some effective strategies or techniques we can all use into our daily routine to promote mental well-being and reduce stress level?
Well, of course, can you guys hear me okay? So stress, of course, is the #1 thing that's plaguing most people for different reasons: health, financial, mental, physical, everything else. The best thing that you can do is, one, get up, get outside, and move. Movement is key for your body. And, you know, nobody's saying that you have to go run uphill at 40 miles an hour, but just general movement every day. Walking, even if you have some physical issues, from your house to your mailbox at the end of the driveway. Get your body moving. Getting out in the sun, increasing that vitamin D, that will help to increase your mental and your physical state.
Wow, that's great. Thank you. What about you, Dr. Banks? What do we need to do to keep our mental, physical health up to par?
So I'm going to take a different approach. Sleep hygiene. So in addition to running up the hill, you also need to go to sleep. So a lot of articles are written about sleep hygiene, and most of you have probably read all those articles. Don't eat too late, don't drink too late, turn off the lights, put away your cell phone, turn off the television. Television doesn't belong in a bedroom. So all those things are important. I heard that. And there's some great websites too. If you go to Johns Hopkins or the Mayo Clinic or WebMD, you can get all those tips and all those issues that can contribute to poor sleep. But as a psychiatrist, I'm just going to make a pitch in a little different direction, and that is that sleep can sometimes be a sign of something more serious. And so disturbed sleep is something you need to pay attention to if it doesn't go away. And almost every major mental illness has a sleep disturbance as part of the symptom picture. So don't ignore it. Try to do your best to do the things that are simple to do, but if it gets beyond that, please seek some help.
Yeah, thank you, Dr. Banks. Heather, before I come to you, Dr. Banks, I want you to expound on that just a little bit more. First, how much sleep do we need? And two, when do we know we're having too much sleep and that we're sleeping because, we're stressed out or have some kind of mental thing going on?
Sure. So there's always outliers. Some people will tell you they only need to sleep 4 hours, and other people say they need to sleep 10, but let's just say 6 to 8 would be good. Should you take a nap? Well, maybe if you've worked hard all day and you want to take a 20-minute siesta, that might be okay. I would say that even if you're sleeping 6 or 8 hours, if you're up and down 2 or 3 or 4 times during the night, that's not a good thing because you've disturbed your sleep patterns.
Wow. All right. Thank you so much, Dr. Bank. Heather, what do we need to do to keep our physical and mental health optimal?
At first, I know there's people who only sleep 5 hours a night, and they coach my 5 a.m. classes at my gym. That ain't for me. I will do it if I have to. But for me, what I've seen, especially when you're starting your health journey or whatever that may look like, is really removing obstacles, addressing those things that might be in your way that might be causing anxiety, confronting those things, whether it's certain relationships or relationships you have with certain things like your TV or your cell phone or food. But removing those and having those really tough conversations first is kind of where I would start. And that may be seeing a therapist or seeing your doctor regarding your sleep, whatever that may look like for you. And then also, being a gym owner and helping people through their health journey is do not compare yourself to other people.
That's good.
Especially images on social media. We can get bogged down. Like, I've done bodybuilding before. They don't look like that all the time. It's the angles, it's the lighting. But comparing yourself to others can really cause a lot of stress when you're going through your health and wellness journey.
Yeah, great. Thank you, Heather. I'm going to keep talking to you and asking you. We've got a really fast-paced world, obviously, and convenience often takes priority. Can you tell us about some practical ways? And I know you said don't compare yourself with others, but how much physical fitness and what outside of walking, as Dr. Williams says, do we need to do? Let's talk a little bit about healthier food choices and movement without feeling overwhelmed.
Yeah, that can be, I say start small or go big. I mean, again, you choose how much you want to bite into this. I tend to coach people to do small steps at a time. Like, maybe let's change what you eat for breakfast.
Yeah.
And then maybe let's tackle a 10-minute walk or workout a day. So taking little small bites out of things so it's not so overwhelming, because we can look at things and we need to change this, we need to go buy all the supplements, we need to get the protein shakes, and you don't have to do all that. So just making little baby steps and little tweaks, I think, is a really good place to start. And then fast pace, we're on the go, whether you only have McDonald's to eat at or Chipotle. I think I can make a decent choice regardless of what is available to me. But what I try to tell my clients is if you don't prep, you prep to fail. So having some type of framework, if you're a breakfast person, making sure you have decent shakes available or an egg and Ezekiel bread option, or some people don't eat breakfast, and that's fine too. Just listen to your body, and I think that'll take you a long way too.
Wow, you said if you don't want to eat breakfast, you don't have to. That's interesting because I think we all grew up with breakfast is the most important meal of the day.
Yeah, sometimes.
So it's not?
No, I mean, I think your body, if you listen to your body, we were hunter and gatherers, so we fasted a lot of the time when we were living as, out in the woods. Like, we didn't eat at 8 a.m., at noon, at 5 p.m. That's just not how we ate as humans. So I think if you listen to your body, and every body is different, you know, and it also depends on women, your cycle, like it can depend on that too, your hormones. So
Yeah.
I think it's just really being in touch with your body and knowing what it needs.
Yeah, thank you so much, Heather. Dr. Banks, you mentioned that we should be more conscientious about electronics and technology, and we are a technological society. First of all, I want to address take the TV out of the bedroom. Where do we watch TV?
Somewhere else.
Right.
If you want to go to sleep, don't have the TV on.
Right.
Well, there's a couple of reasons for that. Not only is it making noise, but it's flashing. And you're not going to go to sleep if it's flashing. Now, you may fall asleep, but it's not going to be the kind of quality sleep that we all need. But if we think about video contrivances, starting with television, you go back to when television was invented, people didn't spend any time watching television. And now we talk about how many hours do you spend watching television, right? So 4 hours, 6 hours. Some people leave the thing on all day and all night. We have the 24-hour news cycle. Gosh, there might be something I would miss, you know. And then come 2020 or so, we've got the smartphone, the cell phone, right? So that adds interactivity to the video. So then you've got some kind of a feedback system going where, hey, I better check my phone because Joe might have sent me a text and he's going to bring me a surprise. But of course, what you really see is that Joe's just going to the grocery store and he wants to know if you want something. So I liken it to a slot machine from the standpoint that occasionally you get a prize, but most of the time you don't get a prize. And on top of that, the casino's making lots of money, just like the cell phone people are making a lot of your money. But it is a choice about how you want to spend your time. And if you want to take a walk after dinner, you might run into a bird. You might even hear a song. So I liken it to giving up an addiction.
Yeah. Can you talk a little bit about how to set healthy boundaries and guidelines for us and our children, the young ones that we may be raising and come in contact with, to limit TV time and tablet time?
Right. So in our permissive society, I think we all need to take a step back and think about what the boundaries ought to be. I don't know how many people in here eat dinner with their family with the TV off and no cell phones, but to me that's the way it would be healthy to do so. But there's a lot of things you could do other than sit together at dinner, but put that cell phone away. I don't know how many restaurants I go into, and there's two people there who are apparently on a date of some kind, but they're not talking to each other. So it really is a choice of what you want your life to be.
Yeah.
Do you want to be tied to that phone, or do you want to have close friends and be able to share your feelings?
Yeah, thank you so much. Dr. Williams, you're a president of the South Carolina Chiropractic Association. Tell us a little bit about what kinds of conditions do chiropractors treat? I mean, I know we probably always think your back, but is it more than that?
So yes, with chiropractors, we treat what we call neuromusculoskeletal conditions. So that's anything involving your muscles, your nervous system, and your skeletal system. And of course, you know, as you stated, most people come to us because my neck hurts, my back hurts,
Or
I
they've
have a
had an
headache.
accident or something?
And had some sort of accident. And that is, you know, our primary conditions that we cover. But with chiropractic, we have what I like to call good side effects. As we are making adjustments to the bones of the spine and freeing up and allowing those nerves to talk to every single cell of the body clearly and efficiently, you know, yes, your neck feels better, your back feels better, but you may notice better digestion, better sleeping, which is important, of course, more energy, and just a better overall well-being in general. So that's our key thing. We focus on nerves, muscles, and bones, but there's so many other systems that we indirectly help as a result of clearing up that nervous system and making sure that, like your information highways, talking to every single part of your body clearly.
Wow, that's fascinating. So we all should go to a chiropractor a time or two then, right?
Absolutely. I see everywhere from 0 days old, still in utero, up to 100 years old. If you have a spine, you're using it.
Yeah.
And the thing that we often don't think about with the spine is, yes, it keeps your body upright. It's a super strong structure, but your spine is a very dynamic structure as well. So as you move, it's moving and flexing with you. So the same way that you maintain the eyes and the teeth, also have to maintain the spine. Because we can put on glasses and fix the eyes, we can fix the teeth, can't do any spinal transplants. So we definitely have to maintain the one that we have.
How often should we go to the chiropractor?
Well, now that's a loaded question. So it really varies depending on your situation. So just a prime example. If I have someone that comes in that just has general discomforts, a little bit of neck pain, maybe some pain in the shoulder, we initially will go through a full exam, full x-ray to determine the extent of your issues and how we can fix it. And it's very hard to just say, hey, we're going to see you 3 times a week for 3 months. Every single person's body is different. So for most people, if you're coming for an acute pain or an acute discomfort, once we're able to settle that discomfort in, let's say 6 to 12 visits, as a routine maintenance, I recommend once a month, just to maintain those changes that we've seen. Initially, you'll go a little bit more just so that we can retrain your body's muscles. But after that, once a month is kind of our general rule.
Okay, awesome. Thank you so much. Heather, I'm going to go back to you. You're part owner of a fitness facility, Warrior Fitness and Martial Arts. Can you share some advice or information about structured exercise regime and healthy work-life balance? How much should we be doing?
Yes, so that's also a loaded question. What I will first say is I really appreciate the makeup of this panel, because at our gym even we focus on, you may need to go to a medical doctor. I've been going to a chiropractor for 8 years now, so I find that every facet of this is important. There's no magic bullet, just to let you know. There's no magic potion, lotion, pill that you can take to make yourself healthy. So I'll just say that first of all. And the same goes with exercise. So the biggest thing I see is, and I was a college athlete, and I was terrified to go into my first CrossFit gym, and we're not a CrossFit gym, by the way, and there's nothing wrong with that, but I was terrified to go in because you don't see machines and you're like, what is going on in here? They're moving weights, and but first of all, just show up, and if the members there are jerks or the coaches aren't nice, you're in the wrong place.
Right.
So we try to create a very, very welcoming environment. We don't allow certain members, we're like, this is not a good fit for you. So, we pick and choose who we want to be in our community, because being in there sweating and grunting and picking up weights after a long day or early in the morning when you just rolled out of bed is a very vulnerable situation possibly to be in for someone. So just show up and finding the right place and try places. And then also variety is really important. That's why we have, kickboxing and general workouts and the martial arts, because I get bored easily. So I'll do kickboxing, I do some weight training, I'll go on a ruck, which is like a weighted vest that I'll walk 5 miles in, or I'll do yoga, I do gyrotonics, I do a little bit of everything, just because I want to keep my body, second guessing, and we don't go in there and do my 50 reps and 50 push-ups, and it gets really boring. So just show up, be around good people is really, really important. And if you fall off, don't get mad at yourself. Give yourself some grace. None of us are perfect. We have busy lives. I have fallen off too, but you just show back up and you do what you can and listen to your body. You're not going to go 100,000,000% every workout. That's just not reality. So do what you can, be gracious, and find a good place to go.
So for folks who either have fallen off the wagon or want to get on the wagon, in the morning, should you stretch? Let's talk about, in the morning, what should we do? In the afternoon, what should we do? Should we do anything at night?
Well, I work at home. My day job, so I have multiple jobs, but my day job, I work at a computer all day. I do insurance, tech. I move numbers around in the cloud, but so I have a standing desk, so I try to be moving all the time. So if you do sit, try to like set a timer and stand up every 30 minutes or so and just do a little bit of spine mobility. I even have my wobble cushion. Like, I'm a practitioner of the chiropractic stuff, even at home. So try to move your spine. You can do some chair stretches, but try to move. Sitting all day is so awful for you. I'm sure y'all can attest to that. It's killing us.
Is
sitting
everybody
all day.
moving every 30 minutes?
Set
All
your
one
timer.
of you.
Yeah. Set your timer.
No?
Yeah.
Yeah, go ahead.
Yeah, so I try to, in the morning at least, do some stretching. I have some bands that I work on just to warm my back up. And I usually walk my dog in the morning with coffee and try to get outside for a little bit. I try my very best to not look at my phone right away in the morning. It's really hard to do. And then also the boundaries with phones is tough too, because we live in a world now, like I work from home, I have 2 cell phones. I'm a business owner and I'm a state house rep, so I feel like I have to be constantly attached to that thing. And I try not to feel guilty about putting it away at night. And that's usually when I'm cooking dinner. I have a record playing usually, and I try to just unplug and spend that time with my partner and just try to relax and not have people pinging me and stuff.
Thank you, Heather. Do we have any questions from the audience at this point? Any audience questions? Yes. David, can we have a mic? Okay. I'll come and bring you my mic.
I'm Gerald Wilson. I chair the South Carolina Behavioral Health Coalition. And the Youth Risky Behavior Survey is done every 2 years by a grant by the CDC. And I might be wrong, but I was made aware that the Department of Education here is not going to do that. The next one is due in 2025. And I've looked at the reports from that, the YRBS surveys for the past several years. And there's valuable information that comes from that about behavior in youth from kindergarten to 12th grade. What are your comments about whether that approach is appropriate or not? Because we don't have information about that. We don't know what to do about behavior in our children.
Thank you, Dr. Wilson.
I have a follow-up question. So this is a survey on of students' behavior. What can you explain the survey again?
It's called the Youth Risky Behavior Survey. It's a grant that's funded by the CDC for states and departments of education, and it interviews children from K through 12 in public schools. It's voluntary, it's anonymous, and it asks all sorts of questions about behavior, including exercise, nutrition, and I guess some of the issues that may be controversial is it asks about gender and gender preference and that sort of thing.
I had heard that we weren't going to do the survey. Do you know what the decision was based on?
That's the reason I'm asking the question, because I heard it and I don't know why the decision was made to not do that.
Well, I would certainly say that a survey of our children and what their concerns might be and what their behaviors and habits might be would be a helpful thing for teachers and the counselors in the school. Whether or not we use the CDC version or create our own version, I don't think that matters as much as getting the information.
Yeah, I would say from a legislator's standpoint, what I do know, without looking at the specifics of that survey, is that when children have nourishing meals, they can focus better, they can pay attention better, they feel better. It helps with, I know, with ADHD and things like that, depression. I mean, so for me, I'm on the Agriculture and Natural Resources Committee, and we are working really hard. I know that's very important for the Black Caucus too, is to feed our kids and feed them good meals and feed them meals from farmers in South Carolina. And then I think the second worst thing we could possibly do is taking away exercise from kids in schools when they're sitting at a desk all day. We need them outside, and that was, for me, my outlet in school was running around and playing on the jungle gym. So I know that's an important thing for legislators in particular to pay attention to. So I'm all for, I also serve on the Columbia Food Policy Committee, so making sure our kids have good food in their bellies is so important. So I'd be very curious to see the results of that.
Thank you, Heather. Dr. Linda Bell, who we're going to hear more from later, has some comments about the survey. Dr. Bell.
I might be able to add just a little bit about the survey. I agree with Dr. Wilson about how valuable this is. And to explain a little bit about the methodology, this is actually a survey that systematically collects information from representative population groups in that age group that he mentioned. And because it's called the Youth Behavioral Risk Factor Survey, it assesses some of the things that he mentioned, but it also collects information about risk behaviors, including substance abuse, smoking behaviors, sexual activity, and things like that in that age group. So it's an extremely valuable resource for us to get an understanding of what is putting our youth at risk from various things. For example, it was the Youth Behavioral Risk Factor Survey that revealed that smoking behaviors in young African American children was increasing at an alarming rate, because young blacks historically did not smoke as much as adolescent whites. So we get information from this survey that helps us understand how to target emerging issues in youth. Now, the survey consists of various modules, and I don't know a lot about this because it primarily focuses on chronic diseases and I'm in infectious diseases. But there are various modules that state health departments, for example, can adopt. You have to pay for including various modules in this survey. So I wanted to explain just a little bit more about the methodology. It randomly selects people to get a randomized survey. The information is actually collected from the parents of those at younger ages. But it is a very valuable resource. So I don't know about the Department of Education continuing to participate in various modules because I believe there's a cost associated with that. But I do want to explain to people the wealth of information that we get from this, understanding what puts our youth at risk and helping us identify interventions. So when we see an increase in substance abuse, in smoking, sexual activity, we design interventions to address those risky behaviors in youth and correct them.
Thank you, Dr. Bell. Dr. Linda Bell, of course, is the epidemiologist for the state of South Carolina. We became very closely familiar with her during COVID. To find out more about Dr. Bell, there is an Amara Woman magazine on your tables, and you can check that out. What's your question, ma'am?
Hi, my name is Dr. Unica Simons. I am a social worker and a public health professional. My question was related to YRBS and also our participation in other CDC surveys like BRFIS and other surveys that give us information. We don't always participate, but much of the information allows us to have information around trends in health, both chronic diseases and infectious. It allows us to have and be able to compare where we are to national trends as well. And so oftentimes we don't participate, and since you all are here and the question has come up, what would be the rationale as to why we would not participate in certain surveys? One, for instance, I know that we did not participate in the caregiver modules for BRFIS in the last iteration. And those modules give us information, not just basic information on how people age, but also who's taking care of people who age, which is critical. Health outcomes can be affected by stress, as you just spoke about. And so how do we, as a state, really begin to address some of the issues that come about if we don't have effective data? And while it may be appropriate on some levels to do our own data, not being able to compare ourselves to both regional and national trends provides a dearth of information, in fact. So that was the first question. The second question I have is, we talked about sleep, we talked about body health, but we didn't talk about mental health. And, just thinking a checkup from the neck up, when you talk about managing and controlling stress, if you're not healthy here, it's really hard to be healthy down below,
Yeah.
you know. So just wanted to know what your thoughts were on that. So those are my two questions. I'm going to stop now.
Yeah, no, thank you so much. We're right here, girl. That was going to be my next question. Go ahead, Heather.
I would love to speak to the first part of your question, Doctor. I will talk about my colleague here, Rep. Alexander is here, but we would love more data. I would love to serve in a body that reads and wants to understand science. That doesn't always happen in the legislature we're currently serving in. So advocating for those issues at the State House, especially as representatives, is extremely important. Making sure we have that data in front of the correct committees and the correct folks who need to read that information and understand that information is extremely important, especially when it comes to science-based things such as our bodies. And I'll leave that there. Thank you.
Thank you, Heather.
On the mental health side, I think it's important that we build into our visits with patients a tool that will help us keep track of their mood in particular. Depression is probably the most common mental illness, and also one that leads to significant disability, loss of function. So at Department of Mental Health, we have it built into our EHR, and I know some doctors' offices and some hospitals have the same, and I think the more that we can pay attention to that as a primary measure when you go in to see a doctor, the more likely we are to recognize something early and being able to do something about it.
And I fully agree with your second part about that checkup from the neck up. Oftentimes, people that come see me for physical pain, they have a mental concern that's manifesting as a physical issue. So as a chiropractor, I mean, I keep a list of therapists and licensed counselors that I can refer to, because you're exactly right. That is a major, major concern right now.
Thank you. We have a question from our online audience, and then I'm going to ask another mental health question. Someone from Facebook, and thank you so much for joining us and asking the question, wants to know, are chiropractic services covered by most insurance?
Actually, yes. Most of your major medical carriers do actually have a chiropractic portion that's covered, and a lot of your Affordable Care Act plans also have what we call a rider, where if it's not covered under your general plan, you can actually add it to your plan. So yes.
All right, great. And Dr. Banks, I want to ask you, there's such a stigma attached to mental health, particularly in minority communities. And we have seen, I think, an increase in mental health issues, particularly among young people since the pandemic. What is the Department of Mental Health doing to help with that? To, one, debunk the myths and make minorities feel more comfortable seeking out mental health, and then to address the issues that our young people are dealing with as related to mental health?
We have certainly seen the effects that isolation have played on young people in particular. If you think about being in high school and missing your junior and senior year, or the first time you go to school is to go to second grade, it's a monumental kind of situation for many of these young people. I would say that it's a rare occurrence for me to have a young male come to my office on his own. They don't want to recognize weaknesses. They want to feel as if they're strong. All of those things that play into not being very communicative. And I would say that among the African American males that we see at the Department of Mental Health, they seldom came of their own volition. So I think there is a significant problem there. Additionally, I think if we look at the issue of feeling like you have to be strong, there's also that kind of problem in the female African American community, where you might be taking care of everything and that's your identity. And sure, you might bring somebody in for help, but you're not going to bring yourself in for help. So we see some of that too. But in particular, I'm concerned about the youth from teenage years up to 30 we know that the second leading cause of death in that group is suicide, right after accidents. So I would say to you that if you have a young person and it's one of your loved ones, and they're showing problems with maybe with being withdrawn or not being with their friends anymore, not being interested in what they maybe were doing before, differences in how they behave. You might say to them, well, gee, what's going on? You don't seem like yourself. And so, of course, they're going to say, well, I don't have any problem. I'm doing just fine. Well, you got to go beyond that, because what you've seen doesn't bear that out. So you've got to become, in a way, your own investigator and figure out what really is going on. How can you connect with that young person and talk a little more in depth? And if it looks like there is an issue, Department of Mental Health has 16 mental health centers around the state, and we serve every county. If you call the number for the mental health center that serves your counties, we will get you in within days, or even that same day if there's an emergency. And there's also a new 988 number that's designed to help in crises. What if you discovered that your loved one bought a gun last week? You'd want to know, who can I talk to about that? And so that 988 number is designed to help you decide what the next steps are. I think at the Department of Mental Health, we have to do a better job of using media to be able to get the message out about why it's good to come in for your mental health, and how it doesn't look like weakness. It's really a strength to take care of yourself. So we're working hard on getting into the modern world with websites and billboards and television ads that we plan to get out there very quickly, particularly now after the pandemic.
Thank you. I want each of you to kind of give a wrap up, and then I'm going to go to Heather to talk just a short time because we want to try to keep on schedule a little bit about the recent fetal heartbeat bill. But if each of you can just kind of give, based on your specific expertise and knowledge, kind of a final remarks and a wrap up to leave with us what we need to do as far as wellness and self-care, and how we can advocate for our family members. Dr. Williams, I'll start with you.
So as the saying goes, if you stay ready, you don't have to get ready. The best thing that we can do is to be proactive with our health instead of reactive. The quicker that you are able to address concerns, or essentially visit your primary doctor and make sure that you don't have a concern happening, the better. You know, thankfully we do still have a medical system that allows us to be treated typically by the provider that we want to, but it is important to address concerns before they start. And especially if you're having signs of certain conditions, please address those things before they get out of hand. That's my biggest concern, is just being proactive with your health instead of reactive.
Thank you so much. Dr. Banks?
I guess I'll just comment off of what I was saying just a minute ago. And really, if you see signs that there are mental problems, whether it be depression, anxiety, sleep problems, don't ignore those problems. You only have one chance to prevent a tragedy. Make the call.
Yeah, my comment would be, you only get one body when you're here on this earth, and you can only control what you can control. So what you put in it, what you put on it, how you treat yourself, how you talk to yourself, mental health, making time for yourself. It would be my main thing. You only get one, so treat it nicely as best as you can. And then regarding the abortion bill that passed.
Yeah, just to kind of give us an update. We know that it was passed. I just want to, just to kind of update everyone what it means, and what, if anything, can South Carolinians do?
Yeah, so abortion is healthcare, and I think this extreme bill that passed is first, the name itself, what they're calling the fetal heartbeat bill, is complete not transparent, because it's technically not a heartbeat at all, and we've had plenty of doctors, back to the doctor speaking, medical-based research and science is not always listened to when we have folks in the legislature who have moral visions for what they want their state to be, and they're pushing them on us, the women of our state. And we know what this does at 6 weeks. It's before women even know they're pregnant. Most times, most of us don't have regular cycles. We don't get a pregnancy test every day, so we're not. If we're sexually active, we don't know what that, or when we're pregnant. Usually at 6 weeks. But what I do know is this impacts the minority population the very most. We have some of the highest infant mortality rates and deaths of Black women across the entire country. We have, I think it's 14 counties that does not even have an OBGYN. So they want these babies to be saved, but who's taking care of the babies? We won't expand Medicaid. We have food deserts right here in Columbia, our capital city. North Columbia is a complete food desert. So looking at the root issues, we're not addressing the root issues. So if I were to say to get involved at all would be to show up at the State House, call your representatives, run for office, talk about science. Science is very important. We believe in science, right, in the medical profession. But this is going to have devastating impacts. We were the only state in the Southeast that would see women for medical, for their health care. And I call it healthcare because what the vision is they show pictures of these full children in a womb. But these are women who do not have a viable fetus in their womb, and they're being forced to carry a dead fetus to term. That is what's going to happen in this state. Currently, as of yesterday, when the governor signed it behind closed doors, there are lawsuits that will be pending. I know they're trying to get an injunction to stop that temporarily while the case is in action. So call your legislators, call your senators, run for office, talk about science. This is healthcare. This is going to impact our minority populations the very most. And let's speak to why we haven't expanded Medicaid. Let's talk about why we have areas of the state that don't have access to good food. So taking care of our women and children is most important, and this bill goes against everything. It's devastating. Honestly.
Yeah, Heather's been a big advocate at the State House for this bill, and we thank you so much for your work. Thank you so much for breaking it down for us. Please put your hands together for our panelists during this Wellness, Self-Care, Mental, Physical, and Nutritional Health Summit. Representative Heather Bauer is with District 75, Richland County. She's also a member of the South Carolina Legislative Black Caucus, and she is co-owner of Warrior Fitness Gym. Dr. Robert Banks, a former South Carolina Psychiatrist of the Year and acting State Director of the South Carolina Department of Mental Health, and Dr. Holly Williams is President of South Carolina Chiropractic Association and owner of Better Health Chiropractic. Thank you so much for joining us. We appreciate it. All right, so before we bring up Dr. Bell, does anybody want a 3-month membership to Heather's Gym? Don't act like it. Can anybody tell me the name of her gym? Now, y'all sound like blah, 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 blah. I saw your hand first. Do you know the name of the, you want but you don't know the name. Do you know? Warrior Fitness, come walk and get your gift certificate. What's your name, hon? Alexia, congratulations. All right, we also have another door prize. Our next name on the list is Will Camp. Will, are you here? Is Will here? Come on up, Will. We've got lots more prizes. Want to thank the folks at the my Chamber of Commerce. You just got some information from them. They've got an amazing program, their Minority Business Accelerator. I'm going to put Naomi on the spot later on and let her come up and talk to you a little bit about this, and they were gracious enough to give us a couple of door prizes also. But right now, I want to mention, are you cold enough? We are working. Are you still cold? Because this lady over here told me that she's getting warmer. She's getting warmer, so something must be wrong with y'all because she's getting warmer. All right. Get you some more coffee. We are working on the air, so we're working on the air. Get you some more coffee. All right, thank you again so much for joining us for the South Carolina Legislative Black Caucus Minority Health Summit. We want to thank all of our sponsors and definitely want to thank all of you. Healthy Blue, Select Health, Grail, Dr. Moses Yuda, who we're going to hear from a little bit later. DHEC has some amazing gifts in your swag bag, along with the South Carolina Commission of Minority Affairs, which again, we're going to hear from them in just a short. PMB Promotionals, we got our great bags from there. Sabriti Hair and Skin Products, Brooklyn Banquet and Conference Center, we've got some door prizes from them, and also Restore Chiropractic Family Wellness. Right now, we want to bring to the stage our next presenter. Please pay attention to the screen. We have a sponsor video from Grail.
Hi, I am South Carolina State Representative Patricia Moore Hennigan. Detecting cancer early gives patients the best chance for survival. That is why I am so proud of my colleagues, Senator Jackson and Representative Yao, for introducing a joint resolution last year that memorializes Congress to enact Medicare coverage for cancer detection tests. I am so thankful for leaders in Congress like Senator Tim Scott for their work on the Medicare Multi-Cancer Early Detection Screening Coverage Act. This bill will give Medicare the ability to cover innovative new screening technologies that would screen for dozens of cancer. Communities of color are disproportionately impacted by late-stage cancers, and these technologies would dramatically expand not only the number of cancers that we can screen, but for the communities that we can reach cancer screening. We look forward to Congress moving on with this legislation this year. Thank you.
That's our sponsor video from Grail, from our former chair of the South Carolina Legislative Black Caucus. Well, we've had a interesting last couple of years due to COVID. Many families lost members. We were affected with our jobs and, of course, with our children. And now we're here at 2023. And many of you want to know what happened, where do we go from there, and what are some of the lessons that we've learned as a state, as a community, because of COVID? Well, our next presenter is going to answer all of those questions and more. Please welcome South Carolina State's epidemiologist, Dr. Linda Bell.
Thank you, Trey, and I sincerely appreciate this opportunity to bring information to you that I hope will be helpful. And one of the topics that I was asked to address was what we learned from the COVID pandemic. And before I talk a little bit about that, I want to mention a few things about what we knew before the pandemic. And first of all, we weren't always able to act on certain things that we were aware of during the pandemic from a public health perspective. And I hope that we will learn from what we knew prior to the pandemic, what we learned during the pandemic, that will help prepare us for future epidemics that we know will come. So, for example, we knew well how to prevent the spread of a respiratory virus that spread from person to person. Because for a century, healthcare providers have worn face coverings or masks when providing health care because they understand that that prevents the spread of diseases. So prior to the pandemic, we understood that face coverings or masks would prevent the spread of this virus. But we weren't, from a public health perspective, actually able to use that intervention as effectively as we could to prevent the spread of this virus. Something else that we knew prior to the pandemic is that the U.S. Food and Drug Administration, or the FDA, has one of the world's most stringent processes for reviewing evidence for the effectiveness of pharmaceuticals, for example, vaccines, prior to approving the release of these pharmaceuticals for use in people. So we understood that the Food and Drug Administration was positioned to rapidly approve a vaccine that had been developed in less than a year that was found to be safe and effective against the virus that was causing COVID. But people didn't trust that federal agency's recommendations that that vaccine was effective and could have been used much more effectively in curtailing what we ultimately experienced from this pandemic. And then the other thing that we knew prior to the pandemic is that we, in public health, we participate in disease surveillance, in a worldwide disease surveillance activity that starts with the World Health Organization and gives other countries, even down to the state level, information about what we might expect for certain emerging disease threats that are circulating in the world. So we had pandemic preparedness plans to address a novel flu epidemic, avian influenza, or other emerging infections. We had plans in place to address what we were confronted with from COVID, but we weren't actually able to use those plans as we had intended because policymakers, decision makers, influencers pushed against the plans that we understood how to prevent the spread of this virus. So those are some of the things that we knew prior to the pandemic that I hope that we'll learn from. But what we learned during the pandemic is that the SARS virus that caused COVID-19 was somewhat unique in its ability to rapidly mutate and to change into various strains. Now, early in the pandemic, we had what I call a missed opportunity to have suppressed the original strain that was circulating. That could have been done effectively with the use of masks, social distancing. We actually did do that relatively effectively early in the pandemic, but then we began relaxing those prevention measures a little bit early in the pandemic. And once we had an ample supply of vaccine during the pandemic, we had another missed opportunity that once the supply was sufficiently available, sort of simultaneously, vaccine resistors and vaccine objectors began pushing against that vaccine. So the missed opportunity is that some of you may recall early in the pandemic, we were talking about the ability to achieve herd immunity. That would have meant that we could have established a fair amount of immunity in the population that would have given us the opportunity to have suppressed the virus early in the pandemic and could have prevented much of what transpired in the following 3 years. So that was a missed opportunity early in the pandemic, and this is a point that I want to make that I hope we will learn in the future, that early preparedness and early action can prevent so many of the consequences that we're seeing now. And additionally, what we saw early in the pandemic was that many of those losing their lives were African Americans in a disproportionate way. We were getting sick and dying at a disproportionate rate, and that was because African Americans are disproportionately affected by underlying conditions that put them at higher risk for complications should they be infected with the COVID virus. And additionally, many African Americans experienced sort of social circumstances that put them at higher risk for exposure to the virus. So for example, in certain work settings where many people who provide essential services were not able to work from home. They may be more required to use public transportation, or they may live in multi-generational housing. So there are a number of factors that many African Americans experience that increase their risk of being exposed to the virus. And then they were also experiencing many factors that put them at increased risk of complications from the virus should they be exposed. So there was they were doubly, there was a double whammy of the COVID virus on African American populations. And so what we saw was a disproportionate number of hospitalizations among African Americans, a disproportionate number of deaths. And something that we should not lose sight of, one of the biggest tragedies was that many African Americans, even among those who were otherwise healthy, did not have underlying conditions like underlying heart disease, lung disease, cardiovascular disease, diabetes, and obesity. Many young, previously healthy African Americans lost their lives early at a younger age. And the consequences of that I think is something that's not talked about enough is the number of African American children who lost their primary care provider. I mean, their primary provider, their breadwinner in the home. So many African American children were actually orphaned as a result of the COVID pandemic. And so these are consequences that we will continue to experience in the African American community long after we hopefully continue to control the COVID pandemic. Or what we're seeing now is actually endemic transmission of COVID virus. So it's still with us. Now, the people with these underlying health conditions, predominantly African Americans, experience these things primarily because of limited access to adequate health care. So they're in a position where they are less likely to have better control of conditions like high blood pressure, heart disease, diabetes, so that those conditions, when poorly controlled, put them at higher risk for complications, as I've mentioned. And so while Black South Carolinians were more likely to get sick and die early in the pandemic, they were also less likely to get vaccinated than as compared to their white counterparts. But through early response planning, we in DHEC and with a number of partners at healthcare facilities, healthcare systems, healthcare providers, but also community-based organizations and community members and community leaders, particularly in the faith community, really stood up to help communicate to African Americans about their risk that they were experiencing. And they helped us in standing up non-traditional sites to receive access to vaccines and testing so that people could be aware of when they were infected and seek health care early. So all of those factors actually led to moving into the pandemic that African Americans were as likely to be vaccinated as whites. So this was a huge success in terms of preventing more of the consequences of COVID disproportionately affecting African Americans. And in fact, African American children were more likely to be vaccinated than their white adolescent counterparts. So this was very encouraging that African Americans were really paying attention to the risk and doing as much as they could to prevent that risk. That's encouraging, and I hope that continues. And so I want to mention some of those partners, like in addition to the faith community that was a really strongly showed up, like institutions like this, like Brooklyn Baptist Church, our mega churches and their leaders made a huge difference in the lives of African Americans and improving the lives of African Americans because they were trusted leaders who conveyed the message that public health officials and healthcare providers were trying to convey. So we recognize, and what we've learned during the pandemic is the importance of communities showing up, that public health officials and healthcare providers alone cannot address pandemics like what we were confronted with without the partnership, the collaborations, and the leadership of other members in the community. And so additionally, the COVID pandemic shined a new light on old concerns about these chronic conditions among African Americans and other people of color. And so going forward, what we must continue to work to resolve these inequities will require a lot of work. And this limits our state's health outcomes, whether they are related to age, gender, socioeconomic status, or any other factor. These are inequities that we have to continue to work to address to remove health disparities. And evidence shows that one of the most cost-effective ways to address health disparities is actually not just assuring access to health care, but it is through addressing the social determinants of health. So what we've really learned that when people live in adverse conditions, in unhealthy environments, that affects their health status. People often don't understand and pay enough attention to that connection. And there's a foundational document released by the American Public Health Association that's called Health in All Policies. And this is a framework, or it's a map, that gives us information about how paying attention to giving consideration to health factors and the quality of life in the development of policies actually changes health status, but not only health status, but it improves other socioeconomic factors, and it improves the social determinants of health, like access to an adequate primary education translates into economic security. It translates into more jobs and more opportunities to work. It translates into safe and secure and affordable housing and a safe living environment, safe neighborhoods. People don't often enough make the connection between that and health. And when we look at health disparities, something else that often gets lost is there may be an attitude that when we look at health disparities, that only impacts subsets of the population. But in fact, health disparities infect the entire population, because one way or another we all pay for it when pockets of our populations are at increased risk, especially if you're looking at something like a respiratory virus that's spread from person to person. If a pocket of our population is experiencing that, then we're all at risk from that. But we all ultimately pay the costs of these health disparities through unnecessary health care costs, through deaths, through the loss of care support for our children as they're growing up. This will be a societal cost that we will all pay for if we don't address these health disparities. So I do want to mention that ways to address this, and one way, because I work for DHEC, is that under the direction of our DHEC director, Dr. Ed Simmer, DHEC is committed to expanding partnerships with community-based organizations, community members, and to work towards eliminating health disparities so that all South Carolinians have a chance to achieve their full health potential. And some of the ways that we do this is through recognizing critical needs to address these inequities. In an effort to reach these different communities at highest risk of having severe illness from their diseases, that we're working together with communities to do a variety of things at our state and local level. And I'll mention just a few of these through both public and private collaborations. And it includes things like at DHEC, establishing the Public Health Office of Diversity, Equity, and Inclusion, so that there will be a senior leader in the health agency in the state to focus on health inequities. That with that leadership, we'll be looking across programs within DHEC, but across programs in other state health agencies, other state agencies, other community-based organizations to figure out what we can do. What are the underpinning causes of health disparities so that they can be addressed? Similar to what I mentioned earlier with using surveillance data from the Youth Behavioral Risk Factor survey. When we understand these underlying factors, that is how we develop interventions to address them. We're also increasing the availability of public health data to provide information to assist in decision-making, to influence policy decisions so that we understand the most cost-effective way with limited resources that we can address health disparities. So it is not really through paying for the cost of health care after the complications have occurred, paying for intensive care, paying for the complications. But if we invest at a lower cost in things like education, we avert those societal costs. And it's been shown through multiple studies, abundant evidence, that it is much more cost effective to do that. And it is much better at improving the quality of people's lives before they suffer from the complications. And so we are embarking upon a process to also hire an agency-level chief inclusion officer to help us address these issues across all of our programs, where we may typically address things from a condition-specific focus instead of looking at a community focus. And this will help us change the lens that we look through which we look at problems. And so eliminating health disparities won't be easy, and it will take time. But the focus on that now will help us get there much more quickly. And successfully addressing them can lead to improved health for African Americans, for other minorities, and for everyone. So I want to make some closing remarks about how prepared are we if we have another emerging infectious disease outbreak. I've already mentioned that we had plans in place prior to the pandemic. So one of the questions is not necessarily how prepared we are to do this, but how willing we are to adopt the plans in place. And so we have to be cognizant of negative influences. Looking at the role that social media played in our ability to respond to this pandemic was something that we had not seen before. Many of us have lived through other pandemics. We lived through the H1N1 pandemic. We didn't have social media then trying to influence people about getting safe and effective vaccines. So that undercurrent, as has been mentioned by our eminent health professional, mental health professional, about the influence of social media, the detrimental influence of social media, that we want people to be aware that any and everybody can put something in social media that is not vetted. That isn't vetted by the scientific community. I think I missed part of that, but
This is a serious situation, y'all. Stop laughing. Go ahead, Dr. Bell.
so you get the point. I don't need to belabor that. But how prepared we are is to address other elements in society, to be prepared to address that, to tell people who they should listen to, trusted officials, not just public health officials, not just your healthcare providers, but the faith leader. Just look at what people's agenda is and what they're trying to achieve. Are they trying to help you or are they trying to hurt you? So be cognizant of who you need to listen to and who has the authority, the expertise to say certain things. Please pay attention to the evidence. And as we, so I want to be cognizant of the time here. I wasn't sure if I was getting the hook or not. But I want to end by reminding everyone that I've already mentioned some of the detrimental impacts that we're going to have to live with for a long period of time after COVID. One of the things that we're focusing now is actually the consequences of long COVID, so that people will, when they resolve their acute infection, they may continue to suffer from complications from any organ system in the body. Cardiovascular system, their kidneys, renal failure, strokes, neurologic problems, behavioral problems. We'll continue to live with that. And the healthcare system is going to have to deal with the long-term consequences of COVID for a long period of time. And additionally, we're not done with COVID. The virus continues to circulate, thankfully at a much lower level, but we still have the opportunity to prevent the fact that in South Carolina, we are still seeing preventable hospitalizations. We are still seeing preventable complications. We are still seeing preventable deaths. The vaccine is available. It's safe. It works. We continue to see the evolution of the virus that's causing COVID. We're continuing to see new mutations that is being monitored at the international level. There's actually a new variant that is encroaching now. It's becoming a little bit more prevalent. We're still experiencing the Omicron variant. So please, in all of your positions, whatever role you play, we know this is a multidisciplinary makeup of leaders here. So please use your influence to help protect the health of South Carolinians the best way that you can, following the evidence. Encourage people to take advantage of preventive measures that will prevent the consequences. And we have work to do, but I am encouraged by the position that we're in because it is at a lower level. We have plans in place. We have mechanisms to improve the quality of life. And so in closing, I just want to sincerely thank the Legislative Black Caucus for convening this summit to address the many issues and the many opportunities. So thank you for your attention. And I don't know if I'm happy to address any questions if we have time for that.
Any questions?
Thank you.
All right. Thank you, Dr. Bell. Thank you so much.
Hey, South Carolina, you can make a choice for your Medicaid health plan. Choose Healthy Blue. With Healthy Blue, your whole family is covered for free or low-cost checkups and prescriptions. plus eye exams and glasses for kids and adults. Get all this and more from a plan backed by the Cross and Shield. The choice is easy. Get Healthy Blue now at choosehealthybluecom/SC and get more from Medicaid.
We want to thank Dr. Linda Bell for sharing with us all of that great information. Hopefully, you all were able to get through your frozen brains and listen and hear and get the information, absorb the information that she shared with us about COVID. I hope that you heard that she said it's still here. So we still really need to be conscientious and think about what we heard in the other panel as far as making sure mentally, physically, emotionally that we are being conscientious about our health, because only if we are healthy first do we have the body to fight some of these other diseases, unknown diseases that are going to come. So thank you again so much, Dr. Bell. We appreciate it. Let's give her another round of applause. And thank you to the Brooklyn Banquet and Conference Center for finding that switch. I've never been so glad to see an off switch before. But you know, the funny thing is, I wasn't even cold until y'all started saying y'all were cold. I wasn't even cold. I think it's a mind over matter thing, the Department of Mental Health. I think it's a mind over matter thing. Anyway, before we get to our next panel, you want to win some more prizes? All right, so we've got 2 prizes for you. The first one, I am going to do another door prize. What about Orton Bellamy? Orton Bellamy, I think. All right, y'all give it up for Mr. Bellamy. Here you go, Mr. Bellamy. Thank you so much. Who are you with, or why are you?
I'm just a volunteer
Okay,
with my church.
not just a volunteer. You are a volunteer with your church. What church are you?
Mount Calvary, number 2 Missionary Baptist Church in Little River, South Carolina.
All
I'm
right.
the health wellness program.
Awesome. Mount Calvary, Little River Baptist Church, number 2. All right. Not number 1. Don't get it twisted. He is with number 2. All right. Thank you so much, sir. We appreciate it. We appreciate you. All right. So I mentioned to you earlier that Dr. Bell was featured in a certain magazine. Does anyone know what that magazine is for the next prize? What'd you say, Regina? Okay. Yes. All right, Regina. Right. Like it's right on your table, but it's okay. Come on, Regina. All right. Regina wants to give it. Who do you want to give it to? You want to give it to this cold lady over here? All right. Yeah, she and I were camping out at the tea dispenser over there. All right, ma'am, I'll come and bring you. Why don't you if you're cold, come on and get up if you're cold. Come on. All right, y'all put your hands together. I said I was going to meet you halfway, but I'm going to come along. I want to know, what's your name and where are you from?
I am Mary L. Carter from Vanderbilt County, representing SkyCap in-house. Woo, woo.
All right, SkyCap. Woo, woo. What does SkyCap do?
We're a nonprofit organization from Columbia, South Carolina. It stands for South Carolina Association of Community Actions and Partnership. We are a hub with Early Head Start and the Head Start program as well.
Awesome. Thank you so much for coming. We appreciate you. All right. She's got on her mask, Dr. Bell. Dr. Bell, did you see she has on her mask? Did she get something extra? A clap, Dr. Bell said. All right. Our next panel is about addressing disproportionate health disparities in minority communities. Please welcome from District 59, Florence County, Representative Terry Alexander. I have a story about Terry, but I won't tell it. I might tell it later on. Y'all clap for Terry. Also, VP for Accountable Communities at Prisma Health, please welcome Ms. Angela Jenkins.
How you doing? Thank you. You don't see it?
And Christian Sora, VP of Medicaid Managed Healthcare, Healthy Blue at Blue Cross Blue Shield of South Carolina. So, were you guys, was anybody in here really popular in high school? No, me either. I was a fat little girl with glasses and braces. Nobody else? Well, I'll tell you, oh, they're still getting mic'd up, so I have time to tell my story. Terry and all of his brothers and his cousins, they were so popular in high school. They like had big afros, you know, and so I'm kind of aging Terry now. And then when Terry and his brothers left school, they shut the school down. They shut the whole school down, y'all. It is no more McClinigan High School. Is that the truth? That is the truth. That is the truth. He's so popular, they shut the school. All of y'all, when all y'all left, they shut this school down. All right, so thank you guys so much for joining us today. We appreciate us talking about this really important conversation, because the interesting thing about it is, I think in minority communities, we know, and we knew even before COVID, that there was a difference in health care for Black and brown people and other people. And I definitely think COVID shone a light on what was going on. So let's talk about, for each of you, are there any successful community-based intervention or programs that have been implemented to address health disparities in minority communities? If so, what lessons can we learn from these initiatives? Can we start with you?
Sure. Yeah, thanks. I mean, first I should say that we were an hour and 43 minutes into the program before somebody mentioned social determinants of health. And I was looking at my watch, just sort of waiting, right? And that's maybe the longest I've been in the last 10 years in any kind of a health event where we got that far through an event before somebody started talking about those aspects of these challenges. So, you know, when I think about, and I should say too, I don't know if I had like 7 cups of coffee to try to avoid freezing. So now I'm like, am I cold still, or is it the caffeine, right? So if I'm jittering, I'll let you guess whether it's the caffeine or the temperature.
You're letting us know what it is and what it isn't.
Yeah, that's right. It's not stage fright though. It's one of those other two. So, you know, as I think about social determinants, I mean, there's sort of 2 paths to trying to address disparities, right? Sometimes you do health interventions to improve health outcomes, and sometimes you think about all the other stuff you have to work on to try to get better health outcomes, right? And that can be environmental policy. You know, it can be, like as you get into, where do you still find, lead in the paint or in the water, right? You know, sometimes it's tax policy, right? It's like the earned income tax credit, which has been shown, you make changes to the tax code and you get better health outcomes because of the options that are available to people when those resources are there. And so, thinking about, where have we seen community-based interventions that can help to improve health outcomes? Well, there's both, right? I mean, so on the health front, I was really glad to see that our panel is occurring while nobody's eating, because the first thing that came to mind for me was the Delaware colorectal cancer program, and that's not the kind of thing you talk about while people are having breakfast or they're having lunch, right? But a few years ago in Delaware, they looked at incidence of colorectal cancer across the state, and they looked at it by population. And what they saw was that the screening rates were twice as high for whites as for other populations. And then they looked at, when somebody was determined to have this kind of cancer, how far along were they? And the answer was, in general, much further along already, which meant less likely to be able to get effective treatment in place in time. And the solution they came up with was pretty straightforward. It was to look at they got sort of 5 hospitals in the room, and had each of those hospitals hire 1 nurse and 1 sort of community liaison, somebody to work with the local groups, somebody who had had a really good connection to the community, knew how to find folks, and could build relationships on trust and try to just get at the basics, right? Improve the screening rates and try to get into communities you historically have not been able to. And then also to put together the ability to finance treatment for those who didn't have coverage or weren't able to afford the screening or treatment. A very straightforward model, right? They hired 10 people across an entire state, and in 3 years, I'm not going to pretend I remember these numbers. I had to go look them up last night. I remember the study. I didn't remember the numbers, right? In 3 years, where they went from as the baseline was that the screening rates for those 50 and older for colorectal cancer were 48% among African Americans and 74% among whites prior to this. And in 3 years, they leveled it out at 74%, regardless of which population group you came from inside the state, which is a pretty remarkable thing. And it reduced the mortality rate for African Americans by 42%. So you think about a fairly light touch involvement. This is a program that cost the state $1 million a year, and it avoided $6.8 million a year of spending on more advanced cancer because you detected it earlier and were able to avoid those kinds of detections. I mean, so it's kind of a nice model in the sense that there's a coordinating role for the state, but it is a local intervention, right? It is one that is built on personal relationships between the sort of the health practitioners and those in the community. So that's sort of a health-based model, but you think about, well, what else is out there? Because sometimes you sort of have to do that, that sort of workaround to get back to health interventions. There was a program brochure that the Department of Justice came out with in the 90s where they looked at, sort of promising models to avoid justice system involvement. And what they identified among a few other models was one that came to be known as the nurse-family partnership years later. But basically it was a program to get home visits by nurses in households, and they would try to connect with a mom-to-be by the end of the first trimester when they could, and build a real relationship between the mom-to-be and a home visiting nurse. And it was interesting because it was published in the Department of Justice newsletter about how to avoid crime, because when they went and followed these kids years and years and years later, they found that based on this early intervention model, both the mom and the child out through the kid's 18th birthday had less justice system involvement, were less likely to be involved in those kinds of conditions, were 60% less likely to run away, 55% less likely to have committed a crime. But also they smoked less, they drank less, and they engaged in fewer risky behaviors too. So the path to addressing disparities, sometimes it's the straightforward health intervention, but sometimes it's working on, through other models or through preschool and that kind of thing. But I've already probably wandered longer than I was supposed to on question number one, so I'm going to stop there. You can tell I used to be an academic.
No, that's okay, because I really appreciate you talking about the nurse-family partnership, because when you look at some of the data in South Carolina, it didn't show positive outcomes for what it was intended to do, but you just highlighted the fact that it had other outcomes that we probably weren't looking at initially around criminal justice and how that influences health in community, and it really does when we think about safe communities and where we live and where we need to begin to actually mitigate criminal and justice involvement for our communities that we're trying to serve. It's actually an interesting take on that study, so I'm glad that you mentioned that as an alternative way that we can improve health in the community. But I agree with what you talked about in terms of how we need to approach this, and I come from California where we've done a lot of work at a community level, and there's one example there around maternal and child health, to talk a little bit about building off of your example, where they've been really successful in reducing maternal mortality rates by a significant amount. I think it was around 20%, and they started at the statewide level, bringing together a statewide coalition that was focusing on, that brought providers to the table, it brought government to the table, funders to the table. They established local learning collaboratives that included payers, it included patients, it included providers, to actually begin developing standards of care, quality improvement initiatives, toolkits that providers could use in clinical settings to improve birth outcomes. And so they started at a state level, but then went to the local level, as you mentioned, to begin implementing this at a local level to improve birth outcomes for moms in California. And I know that, and I'm really appreciating hearing what the state here is doing in terms of beginning to bring equity to the table at a statewide level and making sure that we can also do that at a local level. But the Midlands also has a significant example of community intervention that works. And I'm newer here, about 2 years, so I'm learning about this program that Prisma Health has been very involved in. And it's an excellent example of a public-private partnership. And it's the Well Partners program that has been funded by the United Way, supported by Lexington Medical, supported by Richland County, supported by Prisma Health. And this is a clinic that provides dental and vision services to individuals who are uninsured or underinsured. And as a healthcare system, many times we had individuals ending up in our emergency department with dental issues, or they might have vision problems that could have been taken care of in a different kind of setting. So we got involved through my predecessor and the team before me because we recognize the importance of providing care in the appropriate setting for individuals so that they could get the care that they need and to prevent unnecessary ED use, reduce costs, and get them access to the services that they need. And so I bring that up just because when you think about healthcare, And what we do in the clinical setting, we only have a very limited influence as clinicians in our hospital system to influence health. The rest of it's happening in the community. The rest of it's being influenced by policy that this group is making decisions on. And so it's incumbent upon us to partner with community providers, community-based organizations, patients, to deliver care in community settings that are in more trusted places by trusted providers to actually help improve health overall. And so I mentioned that as a sort of a model of how we need to really begin to think about how we deliver care, because it helps us address some of those social determinants that we're talking about. It also it extends the continuum of care into the community. It empowers community providers and to deliver care that, and partner with healthcare systems to deliver care in the most appropriate places. And I think we need to begin to think more creatively about how we as healthcare systems, how we as government, how we as nonprofits, funders work together to redesign the care delivery system outside of the healthcare setting, because that's where health happens. Health is happening in the community. We can't always do it in clinical settings, and we really need to be creative about how we reimagine the healthcare delivery system out in the community. And so I raise those two as examples of how of good community interventions.
Thank you. Representative Alexander, do you know of any great programs in the PD area?
Well, you know, I was, as they were talking, I was kind of reminiscing about some of the services that are being delivered over in the PD. And I know that McLeod has one that have nurses goes in and meet with kids that are, particularly young ladies who are expecting, and have them in this program where they come on a regular basis. Then we have our Hope Health Community Health Center, which I am partnering with right now to create a men's center, particularly African American men's center. They're actually physically building that facility now, where we're going to go and bring African American men into the center, not have it as a medical center, hospital type thing, but a center where the brothers can go in and feel comfortable talking about their health care. Most of us, and I was talking to some of my colleagues, I said most, particularly African American men, we don't think we get sick until we get sick. You know, so therefore we refuse to go and be checked, you know, do preventive measures. And hopefully this men's center that we are creating, and I'm hoping it'll be a model for the state, that we are creating to allow men to go in and have conversations about their health. We have two major hospitals and a community health center in Florence. And it's so interesting with your conversation when you're talking about health care in the community. Our systems, our healthcare systems does well on the property. But once they leave the property and go into the community, that's where the sicknesses occur. But we get into the hospital, it's cool. And you know, in these major institutions, I think need to start looking beyond their property and start extending and reaching out, going out into the faith community, going out into the neighborhood organizations and partnering with them and have intentional assistance, not just do it, but you know, help with intention. You know, I want to make a difference, and you'll probably see a difference once we become intentional in our service delivery when it comes to health care.
Yeah, Terry, I love the initiative that you are launching in the PD to bring together African American men in a non-health setting, so it's not intimidating, right, but so that they can talk and convene and feel comfortable first. So to that end, I want to ask, as women, what can we do to help men be more conscientious about their health care without being labeled as a nag? There's the $100 million frozen question.
My wife is not in here listening. No, you know, again, we must have that intentional intent. To make sure that whomever you are with, that you care about their health. we just have to start having those conversations about our health. And there's nothing wrong with that. I think the best measure when it comes to health care is preventive measure. And we have that preventive measure by conversating about it. We talk about it. We share it. Say, this is what's going on, this is what's going on, and have that conversation about it. I don't think it is as bad as it used to be. You know, I think that we have the opportunity as a community of people and as a state have an opportunity to do some good things. We just have to do it. You know, we're going to say, okay, let's go find out and figure out how we can do A, B, C, D. And I think just having those conversations about health care is truly important. And you start at an early age, you know, reminding them, reminding your children about health care, you know, what health care entails, and reminding family members about health care and why we should be doing certain things, and just have that intentional conversation.
Yeah. Thank you, Terry, for not answering the question. Angela, welcome to South Carolina, first of all. Welcome to South Carolina. But what do you think about how we can increase diversity in the healthcare communities so that then those people can have more of an idea of how to tackle diversity or in minority communities and things of that sort?
Yeah, this is an interesting question. I thought a lot about this. In my previous life, I worked for Kaiser Permanente. I actually managed a high school and college internship program at that facility, and so got a good line of sight in terms of how to navigate, how to introduce young people to health careers and what that means. I also worked with our graduate medical education program on our medical residency programs and was working with them quite a bit on strategies they could use to increase diversity in the physician workforce. And you know, there's a lot of challenges along the continuum, of course, as you think about it. We don't think it's a one and done when somebody gets into college and they're tracking well, or they're tracking in pre-med and then they go to medical school. I want to go back to what Dr. Bell said in terms of what are some of the core drivers of health. Educational attainment is critical, particularly when you're trying to diversify your workforce. The foundational educational requirements that young people need in the math and the sciences are so critical for them to be successful in medical careers in the future. So if you're not starting with that good foundation, you're starting a little bit behind the curve. You can then provide exposure opportunities to young people through job shadowing, get them around Black professionals that are in healthcare, and to let them see that there are a myriad of positions that they can get into. It's not just the doctor, it's not just the nurse, it's the administrative side too, where you're talking about CFOs, a CEO, when you're talking about lawyers, accountants. There's a whole other side of healthcare that people often forget when they talk about health careers. I worked with Bernard Tyson at Kaiser Permanente as an African-American CEO who started in the records room at Kaiser Permanente. He worked his way up and became the CEO of the company. And that's a huge example of where you can influence health, but not as a clinician, but as an administrator and a leader of one of the larger healthcare systems in the country. And so I think we need to broaden our view of where Black professionals can have influence in healthcare, because those administrators, those accountants are making those financial decisions around what influences health, what's going to be paid for, what will get funded, and how they divert their resources to influence health. And that's a major area of opportunity for us. But back to the clinical side, and I worked with a group called Physicians Medical Forum in California, and what they did was they provided a summit for parents and students that were interested in medical careers to make sure that they were aware of the opportunities around scholarship support, financial support, because those are major barriers for our young people when they get into college. A lot of our young people, we found, would get accepted into college but couldn't go because they didn't have the family support, they didn't have the financial resources and support. So they would get accepted, but then wouldn't be able to go or wouldn't show up because they didn't have those supports. So making sure those are in place. But then once somebody gets into college, say they're in a pre-med program and they're tracking, giving them the mentorship and support when they're there is critically important to maintain their success. Because a lot of young people would get there, but they wouldn't have that support, so they would tend to drop out, or they would isolate, or they would have challenges with the math and sciences, so they track into a different type of career because they didn't feel like they could be successful. So creating that mentorship and support once they get into college is important. Then you get to medical school and the residency. That's an even harder place for people to be, because there's so few of us when we're in medical residency. What we found, I worked with a black residency coordinator at the Oakland Medical Center in California. What she did was, because she found that her black residents were not feeling supported, they didn't have the sponsorship and mentorship. She created a mentorship program for them because they were dropping out of the residency or going somewhere else because they didn't feel supported in that environment. So creating that support for those individuals once they're in that environment is also important for them to then, once they complete residency, get hired into the healthcare system. And so it's not an easy question, because you have to really start at the beginning, and you have to really look at the pipeline and what supports are needed along the way, because there's opportunities for attrition all along the way, because it is challenging. It's a challenging environment, particularly on the clinical side. The other piece I'll say is that in the policy arena, I mean, when I think about who's leading CMS right now, Dr. Chiquita Brooks, as an African-American woman, leading on the policy side, encouraging young people that health can happen in the policy arena as well. And what we've seen under leadership with CMS now is that there are health equity requirements for hospitals that are now being implemented. We're required to track for health equity. We're getting surveyed on that. CMS has a health equity plan, and that's because we have black people in different spaces along the way in healthcare that is influencing how healthcare is delivered, policy decisions that influence healthcare, and how healthcare is funded. So it's probably a long answer, but I think, like really broadening our view around where we can have influence in the healthcare arena. It's not just on the clinical side, it's in the administrative side and on the policy side. And I think as we continue to articulate, we'll actually create more opportunities for people to enter into the field and have influence along the continuum of different careers.
Great, thank you so much. Mrs. Sora, I want to piggyback off of what Ms. Jenkins said about, about making sure that black and brown people are heard when it comes to decisions about healthcare, policy decisions. So how can corporations make sure those things are happening, make sure voices are heard?
Yeah, I mean, some of us up here, many of us in the room are policymakers or former policymakers, right? And the folks who are involved in the policymaking process tend to have really good intentions, and are really good at making policy at people, right? Sitting in conference rooms, looking at reports, seeing numbers on spreadsheets, right? And then trying to make the best decisions you can from some conference room where you're in total isolation from from sort of reality. And one of the things that I think can help to get better outcomes out of that policymaking process is, as you just heard, is to get in the room in the first place, right? And to be able to be part of that process. People who are kind of in the bubble, whether they be running health agencies or running hospital systems or insurance plans or whatever, I think there's been at least some movement over the course of the past few years to try to do a better job of listening and try and do a better job of understanding what people actually need, instead of just saying, we've designed this program and now we're going to do this program at you and then you'll be better, right? There's this kind of accidental air of condescension that I think has come out of a lot of our experiences over the course of the past couple of decades. And we've seen that there's been a fair amount of ineffective health policy, that sort of spun out of all that. So, what are ways to get involved and to get better results? Some are formal, right? So you think about, there have been rules over the course of the past few years that have required that nonprofit health and hospital systems every 3 years have to do a community health needs assessment. So get involved, right? I mean, they have all these public hearings. There's open opportunities for comment and discussion about that. But I think one of the keys to that process is that people tend to focus on the report that gets produced every 3 years and then sent off to someplace and then turned in. But the federal requirements also demand an implementation strategy to go with that report, right? I mean, so getting what you're looking for out of that report is this much of it. Getting in the room to be part of the implementation stage is a lot more important. And in many of these places, it's not that you show up and somebody says no. It's more that you show up, and if you're willing to do the work, people are often going to not get in your way. And I know that at least from the years I spent in government, that was one of the ways things got done, was that if you're the one who's willing to kind of put the effort in, there's real opportunity to sort of drive change through that. One of the things we did I was in part of Pennsylvania's Medicaid program before moving down here, and we set up something called the BAG, the Beneficiary Advisory Group, which is, I'm not in the marketing team. I didn't come up with a name for that one. But every state has to have a medical care advisory committee, which is a group of, sometimes it's practitioners, sometimes it's community members, but folks who help the state Medicaid agency decide how to run and modify the program. And when we were sitting there in our conference room in Harrisburg at the Department of Public Welfare, we're looking at who's on that medical care advisory committee and saying, well, it's sort of the healthcare industrial complex talking about itself. And so we decided to create this parallel, this beneficiary advisory group, and we'd bring them in together, and we'd have them meet first, but we made all the other folks watch that meeting as well, and then we didn't have the formal medical care advisory committee meeting until after the beneficiaries had had a chance to chime in and offer their insights. And we made a lot of policy course corrections based on what we heard from the beneficiaries. And it's something that CMS, the Centers for Medicare and Medicaid Services, just picked up last week. So they've now put out a proposed rule where they want to make the rest of the country use that model that we piloted 20 years ago. There's ways to get, I think, your voice heard and participate. I would not be doing my job if I didn't do a commercial here for annual reviews, right? One of the things that I think healthcare providers and plans are trying to be involved with the community in right now is that the federal law is required that every Medicaid beneficiary, at least once a year, you have to sort of determine again, each state has to make sure that every one of those Medicaid beneficiaries still meets the eligibility rules. Well, we turned that off during the public health emergency. Congress stepped in and said, we're not throwing people off of insurance for the next couple of years. Well, they started that process again on April 1st. And, in this state, we've added 300,000 people to the Medicaid program over the course of the past few years. And we are in the process of pushing them back out the door because that annual review process starts up. And what happens is plenty of folks who are busy or distracted, or they get some form from the government, and they're like, I don't know what that is, I'm not touching it. Well, the problem is if you don't return the form, they throw you off Medicaid. And so, as all of us are working together right now to make sure that people who need coverage can keep it, this is one of those things that, once again, people sitting in some conference room in Columbia are not going to have the relationships they need to get out there and talk to people to make sure that they know what this form means, and it means for them and often for their kids too. And being in the mix for community organizations, being part of the solution on making sure people turn in their annual review form gives you entree that now when you've got other things, you can go back to the Medicaid folks, you can go back to the hospitals, the insurance companies and say, I helped you out with the annual reviews. You need to help me out with the problems I'm finding in my community from a health perspective. So I think, being able to listen to people as they talk about the problems they're facing and explain to them how you think you can help them solve their problems is a great way to get in the door. And I'm Christian Sower, and I approve this message.
May I?
Yeah, go ahead, because I want to ask him a follow-up question.
I think what you said, Doctor, in terms of that continuum, having everybody, or people of color, in particular African Americans, in that continuum from the top to the bottom, and so they can be in the room, not after the decisions are made, but while the decisions are being made. And I think that's lacking in a lot of our health facilities. Decisions are made, this is how we're going to address your issue, as you mentioned, versus coming in and say, well, how can we help? And we are missing that. And I think the systems know that they are missing it. But what are they doing about it until we have these type of conferences that come knocking on your door and say, look, we want you to help us. But we know that the help is out there. We know that people need it. We know that sicknesses is everywhere. And we sit back in our little conference room and say, okay, well, we'll do it this way this time, versus being intentional. Medicaid and Medicare, I think they have a bunch of money in the state that they can spend to help people. and I don't know because of us and the policies that we make, but they're not being helped. Services are there, but they're not being served. Services are there in our hospitals. I'm thinking that hospitals have to do a certain amount of community work. I serve on those community advisory boards, and you're right. They just take the package and put it on the shelf. And I'm like, are y'all doing these things? So we know what it needs. The healthcare facilities, the healthcare system know what it takes. You're professionals. You're doctors. You know what heals people almost. You know what we need to do. And I'm not saying you, but we know what we need to do. We just have to be, again, I can't impound upon that word intentional. We have to be real serious about taking care of people, because if some of us are sick, then all of us are going to be sick eventually.
Thank you, Terry. Mr. Storer, I wanted to ask, kind of piggyback on what you said about making sure that people know that when they fill out these forms, that it's helping them. So how do you make sure that they fill out the forms? What types of outreach is happening to make sure people are filling these forms out for their benefit?
I was hoping somebody was going to give me the answer to that question while I was here today. It's tough. I mean, there has been, not to go full apocalyptic about it, but there's been a real breakdown of trust as a society over the course of the last 10 or 20 years, right? And we see it manifested in so many different ways. The Kaiser Family Foundation does a bunch of studies of opinions and insurance levels and all this other kind of stuff. They just did a new study a couple weeks ago where they did a survey. And there's nothing remarkable about this. You could look at studies for the last 25 years to tell us basically the same thing. But, members from minority groups are less likely to trust the healthcare system. And you can ask the question in a few different ways, and they do. So when you say healthcare system, well, nobody trusts the system, right? But there's an 11-point gap between whites and other minority groups on do you trust the healthcare system, right? So 55% of whites say yes, 44% of all of the groups say they trust the healthcare system. Now, when you say, do you trust doctors, there's like a 20-point increase because people are more likely to trust doctors than they are to trust the healthcare system. And when you ask people if they trust nurses, they do a little better than doctors. Sorry, doctors. But you can see these gaps not just as to how people trust different elements of the healthcare system, for lack of a better term, but you still see, even between doctors versus nurses versus healthcare systems, you still see a very significant racial gap in terms of what level of confidence people have dealing with the system. So part of the reason why, you look at the state Medicaid agency, they've got stuff on their website. They have a dedicated website that is just about annual reviews, and they've got a one-pager that is written in, reasonably, accessible language, but who goes to the state Medicaid agency's website for anything, right? Nobody does. That's not that effective. Well, what else do you have? They send these letters out, but half the time they send it to a letter that's the wrong address because Medicaid members often move around, and they don't always think, hey, what state agency do I need to call with my new address? And then, there's mailings occasionally. Sometimes there's phone calls or text messages. But the contract between the state Medicaid agency and the managed care plans has all these rules that say you aren't allowed to mail anything to members unless we see all the material and approve it first. Well, okay, but how long does that take? So you think about all these ways that we kind of handcuff ourselves. And in many ways, that's what brings you back to community organizations again, right? Because the community organizations, they don't have a contract with the state. They don't have to worry about all these get your materials approved in advance kinds of things. And folks on the ground are far more likely to have real relationships with people and to be conversant and understand where to find folks. And that broken element of trust that we don't have in so many places in our society right now, and probably don't have between state agencies mailing stuff out to folks' households. If somebody comes to you who you deal with on a regular basis, who's a friend of yours, who's had a common experience, who maybe is on Medicaid too, if they say, listen, I got that form in the mail and I threw it out because I didn't think it was a big deal, and then I got thrown off the rolls, and then my kid got sick, and then we had to go out there and try to get a prescription, and I couldn't get my prescription because we didn't have insurance anymore. They can walk you through that whole horror story, When your letter shows up in the mailbox, you're going to be like, I'm going to fill in that form, right? So, I mean, I think that personal connection makes a lot of this stuff more real and helps us to get folks get what they're looking for, which is to have their insurance continue. And so, we're out there sending these letters all day long and calling folks. And I mean, several of us have been on calls even this week talking about what this outreach strategy looks like. But that top-down from a distance model has real limitations. And you've got to be able to work with folks who've got personal relationships, or else you're very unlikely to be able to be successful in these things.
Yeah, absolutely. Terry, you look like you're thinking over there. Did you have anything? Okay, all right. Ms. Jenkins, I want to ask you one final question before we go to the audience. Do we have any questions from the audience? Okay, Chris. All right, great. I'm going to walk and talk with the mic and come to you, Chris, and then I thought I saw somebody over there. But I wanted to ask you, Ms. Jenkins, in your opinion, what are some of the main challenges that minority communities face accessing quality health care, and what strategies can we implement to address that, to overcome these barriers?
Yeah, I think we talked about quite a few already when we talk about the obvious ones, so the social drivers of health, and we talk about transportation, access, affordability, insurance, having to choose between paying for your medication versus food. I think we've all talked quite a bit about that.
The stigma.
And stigma, right, related to all of that. When you're thinking about that, the rurality of the community here, coming from California, I think all of South Carolina is rural. I grew up lived in the Bay Area, but it's a very rural place. And so we've got the rurality of South Carolina that are medically underserved communities, so people don't have access to primary care, they don't have access to specialty care. But I think, and then you've got the bias that's in the system, implicit bias that's in the system, just inherent in many systems in healthcare significantly. I can't underscore the challenge of trust, and I think about going back to the maternal child health crisis that we are in for Black women in America, is a major trust issue. And I'm going to tell a story about a Black physician that I know, who wants to have a child, and she's in the healthcare system, and said to me she is afraid to get pregnant and try and deliver in the healthcare system as it is structured today. And that's massive when you've got a physician who knows how to navigate the system, understands what questions to ask, can advocate for herself, who's afraid to have a child in the healthcare system. That's something we cannot not pay attention to, and we must address as a society. And I think we all know that. But I also think that there are the invisible barriers that the average person wouldn't know about. It's how healthcare is financed and funded. There are interesting misaligned incentives in terms of how healthcare is funded. When you think about the maternal and child health population, I encourage you all to watch the documentary Aftershock if you haven't heard about it. It's about two women who unfortunately died after having babies, but they do a really good job of talking about how health insurance funds certain services, C-sections versus traditional births, and healthcare reimburses more for C-sections that take less time to do in the healthcare system. So the healthcare system is getting paid more for the C-section than a traditional birth. And that takes less time. So that's a misaligned incentive when they know through data that there's more risks to the mother and risk to the child when they do a C-section. So you just have to think about that and sit on that for a minute in terms of an invisible barrier that the average person might not know about that erodes trust, but also erodes quality of care in the healthcare environment. But there's also opportunities where we were talking about policy solutions and what things are paid for. Not to mention California a lot, but in other states, they have waivers around Medicaid and what Medicaid will pay for. South Carolina doesn't do waivers, I believe, here. And so they have a waiver in California where they can use Medicaid dollars to pay to address social health needs for transportation, et cetera. But there is an opportunity in South Carolina, it's called in lieu of services. And you don't have to have a waiver to do in lieu of services, and that will allow for funding to pay for, to address social health needs. And when you think about where health happens, as we talk about, happens in the community, the social drivers are the things that influence inequities in healthcare. If there's an opportunity to pay for services to address those, I would think we should take that opportunity. When you also think about care teams and what how care teams are reimbursed. It's usually the nurses and the doctors, et cetera. But we know that doulas and community health workers, there's evidence, emerging evidence that shows that bringing them and integrating them into the care team improves health outcomes, improves quality, reduces cost to the system, builds trust because many of these people are representative of the community. They speak the language of the people that they're serving. They're from the communities that many of these people live in, and so they serve as a bridge to the healthcare environment. If there's an opportunity to create funding opportunities, to reimburse for those positions, to get folded into the care team, healthcare systems would do that. But right now there's not funding to include them in. So I think you have multiple barriers. You have the visible barriers that we experience every day, and you've got the invisible barriers that the average person doesn't know about, so they can't advocate for those services or support because they're not aware of them, that also influence people's ability to engage in healthcare, to trust the healthcare system, and have good health outcomes. So.
Thank you. We had a question right here. Chris, you had a question.
My name is Christopher Lightsound. I'm with the AME Church, and thank you. And we came together in 2019 to do a partnership with the Alzheimer's Association. And when I say a partnership, it's a real partnership, because the Alzheimer's Association put their money where their mouth was. They decided to give us $100,000 for 5 years to do awareness to the African American community about Alzheimer's, education, and advocacy. They sent us to DC for this bill called the ENACT Act. The ENACT Act is a bill that focuses on African Americans being more in clinical studies than our white counterparts. So and my question is for you two folks with the healthcare industry. Are your organizations willing to put your money where your mouth is for these faith organizations like the AME Church, like Brooklyn Baptist, to get the information out? The AME Church has over 250,000 members here in South Carolina, and about 500 churches. So when you're talking about getting these letters and sending them out, because I used to work with South Carolina Medicaid.
Yeah, me too.
We're talking about getting these letters out. I remember them people not opening them and throwing them away and that sort of thing. So when you have a partnership with the Health Commission of the AME Church or the Health Commission here of Brooklyn Baptist, the people that come to these churches, there's a lot of them, and they can get that information out to the folks. So I'm hoping that you all can talk about what partnerships you have with the faith-based communities. Thanks.
Yeah, I mean, I think traditionally the community health team before I got here has done quite a few events with faith organizations in the communities, and I think we're interested in continuing to do that. I think COVID did put a damper on some of that activity, and so I do think you're absolutely right. I think that's the opportunity to get the word out, is partnering with faith organizations, partnering with community-based organizations. I convened my team when we knew redetermination was happening and saying, how can we as our community health team, I oversee a community health team of community health workers, case managers, Healthy Start program, use our staff to get the word out to community, because we knew that was one of the ways that we could actually get information to people and encourage people to make sure that they opened those letters and saw what was going on, to leverage our team. So we did do that. So I do think there's absolutely ample opportunity to figure out how we partner together to get information around redetermination out, but also about just basic health information with community partners. So.
We have another question, ma'am.
Hi, my name is Sheila Albergotti, and I'm the organizing outreach coordinator for the South Carolina Association of Community Action Partnerships, the whole group right here. And my role is to get the information out regarding the Medicaid renewal, so I'm glad you brought that up when we're talking about that. In fact, I just sent information to the bishop's office so that can be disseminated to the 7th district. And so that is so important, and I'm hoping that if anybody wants some information, there's flyers. My role was funded through Community Catalyst, which is an organization about health justice, and so that's the whole goal, is to get the information out to everybody. So I'm glad that you brought that up, because everybody is going to need to do this recertification, is that right? Everybody's going to have to do
Yeah.
that. So can you speak to any of how are they going to, what's the whole rollout or unwinding process for this? Because, I mean, that's a lot of people. And I already know that some people in other states have been terminated because of the things that you mentioned already about how their addresses change and that whole process. Can you speak to how are we in South Carolina going to handle this volume of folks that are going to have to go through this recertification process?
Sure. So each state was required to file a plan with CMS that explained how they intended to address the redetermination process. And this state's plan was pretty aggressive. So the plan that this state came up with was to start with the Medicaid beneficiaries who they thought were most likely to lose coverage and send them the letters first. Now, I mean, I don't get it, but what we've seen so far is that, and this won't be a surprise to anybody who's been involved in this stuff, because this is exactly what we saw 10 years ago, the last time we had a couple years of not doing redeterminations and then they started up again, which is that nobody knew what they were doing, right? So there are clearly logic problems written into the computer software that produced the letters, or in some cases didn't produce the letters. So we're seeing some cases where people are showing up on the list of beneficiaries to lose their coverage who it doesn't seem like maybe ever got a letter in the first place, which is not the way it's supposed to work. And we've asked lots of questions about that and are still talking to the agency, so we'll see sort of more to come, I think, on that front. But because of the decision to start with the groups that they think are most likely to drop, it means that the first couple months, we're going to see lots of people lose coverage. And what will happen, which I'm reasonably confident what will happen, is going to be a lot like what happened in 2015 and 16, which is that people who lose coverage, in some cases they will lose coverage because they don't meet the rules anymore. And that's a sort of a separate policy problem. But many of those who lose coverage because they didn't return the form. And they lose coverage for what they call administrative noncompliance. And what will happen is that if those people still do meet the eligibility rules and they just didn't turn in the piece of paper, the next time they interact with the healthcare system, they're going to find out they're not insured anymore. And then they're going to have to go and either find that letter and fill it in and turn it in late, which may change how they get covered for Medicaid. Or if it's late enough out there, they might have to go through the whole application process again, which can take an awfully long time too. And particularly if the way you find out about it is when you go to the pharmacy to get a refill on some prescription that you really need, and you think you're going to get that bottle filled in 15 minutes, and you find out you don't have insurance anymore, you're not going to get that thing filled in 15 minutes, right? You're going to have to go through some amount of messing around. So who is losing coverage first? It is those who were sort of older adolescents at the beginning of the public health emergency and maybe have aged out of one of the children eligibility groups. Those are folks who are likely to be dropped in this sort of first wave. There's a group called parent caretaker relatives, right? So you can get Medicaid coverage if you have a kid in your household who is on CHIP or Medicaid. But you can only get that Medicaid coverage if your household income is below 2/3 of the federal poverty line. So if you work a couple extra hours or you get a little bit of a promotion or something, it's pretty easy to go from 65% to 68% of the federal poverty line. You can income out of Medicaid eligibility as well. And so those are the groups who are disproportionately being tossed off the rolls here right now. But the mailing of the letters started again April 1st. June 1st is the first day in this state that people will start to lose Medicaid coverage because of the annual review process. And the draft numbers that I've seen over the course of the last couple of days suggest that something like 130, maybe 140,000 people are going to be on that drop list on June 1. And we are working, a bunch of us right now, we're working on projections for what we've seen so far for what might happen on July 1st. And I mean, at least the draft numbers I'm seeing for July 1st don't look that different than June 1st. So, we're on track to maybe lose a couple 100,000 members over the course of the first 2 months. Now, that curve should sort of smooth out after that. That's a pretty big shock. And if you're the person who's at the pharmacy trying to get your prescription covered, it's going to be a real big shock. And so, all of us, I think in a perfect world, more people would have been on the front end of this and trying to manage this process before we got to where we are now. But I think at this point, the reality is that many of us are in kind of cleanup mode, and we're going to be helping people figure out, after this happens to them, what they have to do to get back in.
Thank you, Mr. Sawyer. We have a few more questions.
Good morning. And thank you for everything that you've shared this morning. I'm Susan Burrows. I'm a healthcare executive. Love to hear about any initiatives that you guys have worked with the local school districts. I know Angela shared a lot about different programs that were implemented in California, and I know Terry shared some frustrations of things of loving to hear more about having representatives on that non-clinical side as well. Have we looked at maybe leveraging any of the funds from Department of Labor to look at creating a pipeline of folks that do look like us that are serving in other areas? I'd love to hear about some of the initiatives that you're working on in that regard.
Well, we're in Florence, particularly McLeod and MUSC and District 1, Florence School District 1, we are creating that partnership. As a matter of fact, we're going to be remodeling a building for kids, for students, District 1 students to have access to it, to this whole healthcare, creating that stream from middle school, high school, college, and back to the healthcare system. So we are creating that as we speak, and we're pretty excited about that. We've got some state funding, and then McLeod is going to put some in, MUSC is going to put some money in, and District 1 is going to put some money in too to maintain that ongoing progress. But we are putting that in place as we speak right now in Florence.
Yeah, in Prisma Health, we have our MedX Academy and nurse externship programs where we work with high school students, rising seniors. We work with the HBCUs in the area to introduce young people to health careers, and we have shadow days. So we have a number of programs where we're working with the school districts and local HBCUs to introduce young people to health careers. We also have a number of community health programs in schools. As you're probably aware of, we have Teen Talk, which is a program that was around, healthy relationships at the college level. We offer telehealth services in a couple of schools within the area. We provide social health services to young underserved communities and families in different schools. So we have a number of school-based health initiatives that my team oversees in Richland County and in the Midlands area. So we're addressing it from a couple of levels in terms of the career pipeline work, but also making sure that we're bringing care to the communities in the places and spaces where they live and go to school. So we have a number of programs on both sides through Prisma Health here in the Midlands that are addressing some, I think, the question that you asked.
Yeah, this is the part where I admit that I've only been at Healthy Blue for 2 weeks. So I've asked these questions. I don't have all the answers to what exactly we're doing yet, but I can tell you that my wife's a third grade teacher, and any of you who are, close to teachers, who are related to teachers, married to teachers, being a teacher these days is like being a social worker who occasionally does instructional stuff, right? And good and bad. I as much as I've been beating up the Medicaid agency, I ran it for 3 years, and some of those problems are probably my fault. But she comes home. We do casework every night, right? She comes home and talks about what her kids are up against and what she's seen in the classroom and what problems they're having. And then I go, okay, well, this is the guy. You call this person, and then you tell them this thing, or you give them this form, or send the parents this address, or tell them, try this. And if they don't like the answer they get, tell them to call me. And all day long, the interaction between health and education it's so present in our lives. So I don't have the full list yet of what exactly we do at Healthy Blue. I was hoping to know by now so I wouldn't have to give an answer like the one I just gave, but I'll know soon enough.
All right, we have a few more questions. Benita?
Good afternoon. My name is Benita Clemens. First, I want to say thank you to the Black Caucus for having this summit, and thank you to everybody for being here. So I have a statement again and a question. My statement is, there's been a lot of research. I was in graduate school in 1992, and it seems to me that even since 1992, we're talking about the same problems. So does anyone feel this way? I feel that enough money has been put in research to determine what the problems are. Let's put some money in the solutions. So I'm just wondering if I'm the only one that's feeling that way. Number one. Number two, Angela, can you talk a little bit, because I heard about a wonderful initiative that Prisma is going to be rolling out with the Blue Zone in terms of Richland County. And I have an organization named Diane's Call, and we are really sick and tired of hearing all of the bad things about 29203. So we decided to go in and put some programs in this neighborhood. And we've started things with the children, and we've started a once a month with a doc. So I want to call out Dr. Rojas for coming out and talking to us once a month. We want to change the narrative. And we know that we have to do it. It cannot come, I think in the past it's been from the outside in, but now we're on the inside. So we're going to try to do it from the inside out. And I would like to say, everyone who would love to support or come together, please let us know, us meaning the boots on the ground. The sister, she's not here right now. She's been on the ground for a long, long, Centrell Thompson, and a lot of us here. The ones that are on the ground, I feel doing the work, the hard work, everybody's working. We get pennies. You know, I grow food and I'm a farmer and I work with a lot with the USDA, and the money stays up here. We need the money to come down and help those who are doing so much work. And again, I know we all work hard, but we really, 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 I'm asking for community-based organizations and anyone else who is doing the work. How do we draw down the money to help these organizations sustain themselves, because we work without enough resources all the time? Thank you.
Thank you, Benita. I'm going to go here. We have a high schooler who has a question, and then I'm going to go here.
Thank you. Excuse me for not standing up, but I'm really cold right now, so I'm trying to keep warm. Hello, my name is Shadea Caldwell. I first wanted to just take a moment to introduce myself. So I'm a USC alumni, and I am the founder of Black Girl Magic, which is a wellness company where I have facilitated healing and empowerment spaces for over 30,000 women. I was featured in Oprah Winfrey Network at 23 years old, and I have gone on to tour across the United States and speak around the world. And now, you know, being that I've lived in New York City doing majority of that work and also in Los Angeles, I'm really eager to come back here and figure out how to implement that, especially for Gen Z and millennials. I think there's really a disconnect around mental health. And also, you know, even me coming here, being really excited to hear about mental health, I feel like I didn't hear that much about it. And so I would like to see, you know, more programming around that and being involved in the programming as well. But also really curious about mindfulness, and so yoga and meditation, how these things could be implemented into the school systems. Because the very reason that I started Black Girl Magic is because I had a mentor group that I experienced going to Ridgeview High School. And so that was the reason I started my company, and I know that being able to have those type of experiences at a very young age can really take the direction of someone's career, someone's passion, and also empowering themselves. So my question to you is, what are the ways that you are doing that? And if you're not, what are ways people like myself, a 29-year-old entrepreneur, can get involved?
I'll take it first. We're all looking at each other. I'll take a first shot at it. So I mean, one of the things that I often find myself doing in cases like that is I try to figure out, you know, so one, you sort of figure out, like, who do I want to work with, right? Do I want to work with the state directly? Do I want to work with insurance companies, hospital systems? You know, like, who can work with me to implement that kind of a model, right? And I figure out how they get paid for stuff, and then I figure out how to explain what I can do to make them more money so that they can afford to pay me, right? You know, and often that's the game that we wind up playing in, you know, at Health and Human Services or at some of the insurers. A few minutes ago we talked about waivers a little bit, and in many ways that logic is what is behind many Medicaid waivers. Is, you know, because at the end of the day, a Medicaid waiver is just a state government asking the federal government for permission to run the Medicaid program differently than what the regular rules say. And the regular Medicaid rules are, you know, are decades old, right? It's, you know, if you do this kind of a service, we give you this much money. And it's a very transactional kind of an exercise, but it's not necessarily one that's really designed to get better health outcomes. And a lot of the waivers are designed to focus more on what is the change we're trying to bring about in society and in terms of health outcomes, and sort of backing into things from that goal, and then building a financing model that fits that goal. So I think as you take a look at sort of who you want to partner with from an insurance perspective or from a provider perspective, often the materials are out in the public domain about how they get reimbursed. And so sometimes it's they get paid based on their quality scores, right? So a lot of federal programs now pay hospitals or insurance companies based on how they do on certain metrics. I would go look at those metrics a bit and think about, if my model is successful, if I can change the way that people think about wellness, about their personal, I think, health-related behaviors, how am I moving the needles on those scorecards? Because then you've got that sort of story to tell when you go and meet with the insurers or the providers and say, I can help you move the needle on that metric, and that's how you should be able to pay me to do this work. And more what we see between, I was on a call yesterday for an hour and a half of Prisma's leadership and Blue Cross Blue Shield's leadership, where we talked about, sort of this new sort of shared savings model we have, where we work together in a way that historically we haven't. And when we are able to move outcomes together through that common effort, there's money to come back into both organizations to pay for these kinds of undertakings. So I think getting people to think about how your model fits into that sort of value-based purchasing model is probably the best path to getting traction with those folks.
I would just say in terms of the mindfulness and mental health, it's just a matter of awareness and how that influences health. And I think that can take some time when people aren't really familiar with the connection between mindfulness and health. And I would suggest small tests of change. In my previous experience, I remember we had an organization that came to us that wanted to talk about yoga and mindfulness and meditation in the schools, and the reaction was really strong. I was like, what is that? But it took time, right? Because there's a lot of stigma attached to that, and people view that differently. So I think small tests of change around that is really important, and partnering with like-minded partners to do the case building around how this can be effective, particularly in a school setting when you're talking about discipline and you're talking about the school to prison pipeline, I call it, when you're tracking kids into, say, detention or whatever because of their behavioral issues. If you can actually introduce mindfulness into those settings, you can reduce that from happening because you're creating that space to be mindful, to be calm, and you can help address some of the behavioral issues that way, and that's been proven to work. I think the mental health issue is challenging. When we did our community health needs assessment, mental health is number one on our needs assessment. But we know that there's a lack of providers in the community. There's a lack of cultural competence around providers in the community. There's a lot of stigma still around mental health. So we're just still needing to overcome those barriers to begin to figure out what do we do around mental health. It's a very complex issue. Where do you begin? How do you start? And I think the earlier you can start with mental health, early childhood mental health in the schools is critically important. So I think, continue the work that you're doing, continue to raise awareness around all of it, find those like-minded partners, because eventually we will get there. It's just going to take some time.
Terry, did you have?
Yeah, because I think it's about them trusting you as much as we trusting you. And I think you have to develop that relationship, and that is a time consumption type thing. Show your worth, show your value. You know your value, but others may not see your value, and you have to slowly let them see with small successes, if you will, and allow them to see that you can be trusted to make a difference in the community, because everybody wants good outcomes. And I think that's crucially important, show that you can bring about certain outcomes in the community.
All right. So we can stay on schedule and respect to everyone's time. This is going to have to be the final question in this segment. If you have questions or comments afterwards, we'll be glad to either give you an opportunity to speak to our panelists, or at the end, if we have more time, we can get more questions. Okay. One of our high school mentees at the South Carolina Legislative Black Caucus has our final question.
I'm a rising senior at Irma High School, and it is very rare that my peers talk about the importance of healthcare. Oftentimes, there's a mistrust with African American communities in the healthcare system. I would like to leave this event with information on how I can encourage my peers to take their health more seriously.
Thank you.
I was on a panel in Vegas this past year, and talk about chronic kidney disease and the impact that it has, particularly on African Americans, chronic kidney disease. And so we started having this conversation about it. If it says if you count 1, 2, 3, 4, 5, 7, 8, 9, 1 out of 9 of us, or 9 out of 10 of us, African Americans, have some level of chronic kidney disease. It may not be as drastic in terms of being on dialysis, but it's there, and we have to deal with it. And I'm saying all that to say that sometimes we have to take care of ourselves, young man. The system hasn't been that trusting historically, but we are finding out because of the doctors that we have that they're at the table now. Some of the doctors at the table, African American doctors at the table now, helping make some decisions that affects your life and my life. So as long as we keep increasing the number of physicians, the number of healthcare providers, and having them at the table, you begin to see a difference in terms of quality of healthcare that we're receiving. 20, 25, 30 years ago, that may not have been the case. And we'd have been relying on the ivory towel guys.
You're pointing at me because I talked about it,
Yeah,
not because I'm that guy. I just want to clarify.
Y'all guys. The ivory towel folk who are making decisions on our health care. And it's interesting because you said something about these two ladies, the sister that had his baby was afraid. That's interesting because she has health care, but still not receiving good quality care. Isn't that interesting? Got health care, but when you go into these health facilities, you still have some question or some doubt about receiving proper care or quality care. And that does exist. That's that little underlining piece that we don't like to talk about, but it is there. I have insurance, but when you go to the doctor, am I getting the best? I don't know. Some issues.
I would encourage them to go into health careers. I'll put that plug in there, so we can change that narrative. And I think, just the fact that you asked the question and just making a little bit of what you're talking about, engaging with one another and having these conversations, having honest conversations about it and supporting each other through those decisions, I think is going to be critically important, encouraging them to engage in their own health. And again, I want to put that plug in there, go into those health careers so we can change the narrative and change the dynamic of what healthcare looks like moving forward.
Yeah, I like your question because if our healthcare system worked, it wouldn't need you, right? And I say that not just because my daughter goes to Irmo High School, and she's in the health sciences program at Irmo High School, to do another little commercial. But I spent 16 years working for the government. I didn't go into government because I thought the government worked. I went into the government because I thought it didn't work, and I thought I could probably do a little bit better, right? And I think we shouldn't be looking for a job where we think everything's perfect, right? The whole point is to have an impact and accomplish something, right? So if you don't like the health system we've got, get into it and make it better, right? I wouldn't narrow that, advice to healthcare. In all of our undertakings and everything we do, that's the whole point, right? Is to have some kind of an impact and accomplish something. So the folks you're talking to at school, I hear them. I get it. I don't. Trust me, I've been inside that system. I don't trust it any more than you do. but the solution isn't, I think, to turn our back or get frustrated. It's to get out there and do something about it.
All right. Please put your hands together for our panel. Mr. Christian Sora, VP of Medical Managed Care, Healthy Blue at Blue Cross Blue Shield of South Carolina. 2 weeks, you said you've been there?
2 weeks.
2 weeks, brand new. Also, Angela Jenkins, VP of for Accountable Communities at Prisma Health. You welcome also. 2 months?
No, 2 years, almost 2 years.
Oh, 2 years. All right. You from here now, girl. And Representative Terry Alexander, District 59, Florence County. Thank you all so much for joining us. Thank you for your time, and thank you for sharing your area of expertise. Please put your hands together for our panelists. And thank all of you for your questions. All right, as we get ready to transition into our working lunch, we've got 2 more prizes, Minority Business Accelerator notebook and pen from the South Carolina Chamber of Commerce. Does anyone remember what high school I said Terry went to, and after he graduated, they shut the school down? Does anybody remember what school that was? No? What'd you say? McClinigan, you're right. All right, here you go. I'm going to let Terry take your prize. Terry, take this gentleman his prize. You could come and get it. Come on. Come on. He's not going to come. Come on. Y'all can clap. What's your name, sir? Marcus Smith. And you're with what? Who? All right. Thank you so much. Thank you so much. And then someone else from our door prize. Let me see. What about Alexia Hopkins? Is she still here? Alexia Hopkins? Did you win something? Okay. I thought so. Jeffrey Ham. Is Jeffrey Ham still here? Jeffrey Ham. All right. Here you go. Another prize from the South Carolina Chamber of Commerce. After this video from Select Health, we are going to transition into, thank you so much, sir, for coming. We appreciate it. We're going to transition into our working lunch.
Hi, my name is Michelle, and I work for First Choice by Select Health. Our First Choice Community Center is open to the public and our members. Some of the services that we offer through SC Thrive are tax filing through Benefit Bank, FAFSA, SNAP, voter registration, and Medicaid applications. We look forward to seeing you soon.
We spoke with one of the ladies in the back, the lady with the beautiful gray hair mentioned, she was one of the people that asked a question. She has Medicaid renewal information. She says if anyone is interested in getting a flyer to distribute about Medicaid renewal, you can contact her. It's SALBERGOTTIE at SCACAP.org. She's with the South Carolina Association of Community Action Partnerships. She's right there in the back. Ma'am, can you please stand? She's got a beautiful gray hair and a blue jacket on. I want my hair to look like that when I grow up, I tell you. She's got Medicaid renewal information. All right. You guys still doing okay? All right. Thank you again so much for joining us for the South Carolina Legislative Black Caucus Minority Health Summit. We are getting ready to do a working lunch, so please welcome our presenter talking about cardiovascular issues, diabetes, heart disease, stroke, and hypertension. Please welcome the Clinical Assistant Professor of Internal Medicine at the University of South Carolina School of Medicine here in Columbia, South Carolina, Dr. Moses Udall. He was sitting over there looking at me like he was trying to figure out who I was talking about. You, sir. Thank you.
Good afternoon. How's the lunch? It's good? How's your lunch? Why are you waiting for your lunch? Why not wave to anybody that you know? Wave to her. Wave to him or her. Say hello. Say hello. All right. Anyway, I'm here to talk to you today about something that you know. It's not something that you don't know. I'm here to talk to you about something that you already know. I'm sure you've heard about heart disease, hypertension, diabetes. But at the end of this session, I want to empower you so that next time you go to your doctor, you know the right question to ask. Because I think most of the time when people come into the hospital, they come with stroke, heart disease. After we see them, treat them, we go through all the medicine. The question is, how come my doctor didn't tell me this? So I think there's a disconnect between the patient and the doctor in the office. I'm not here to tell you about heart disease that I try to lecture you, but I am trying to come here to empower you to know more so that you can take control of your situation. I was born in Nigeria. I came here after high school. I went to USC. Then after USC studying biology, I went to medical school in UIC, Chicago. Then I went to do my residency in NYU, and I love South Carolina so much, I came back here. So I am with Prisma Health, and I've been practicing for 20 years now. I'm a hospitalist, which is a branch of medicine that we see patients only when they're sick and come into the hospital. So then I am also a clinical assistant professor with USC. So I teach resident, I teach student, and I teach resident doctors on how to be good doctors. Because we don't need doctors, we need good, competent doctors. So when we talk about heart disease, and we know where heart is in the chest. So this is a disease of the chest, the heart that is in the chest. When we talk about stroke, it's the same disease process, but it's in the brain. So what led us to where we get these issues? Next slide. All day you heard about health equity. So what is health equity? Those of you that work with CDC, Dr. Bell, you know the definition of health equity, and I'm not here going to read word to word for you, but the health equity has a lot of history behind it. It has a historical and contemporary injustice, which include overcoming so much economic and social obstacles. Now, you might say, how does this contribute to my health issue? For those of us who are in medicine, there's one word that you have to know. It's called inflammation. When you are stressed, you know the word stress? Stress leads to inflammation. How does this inflammation affect your body? The body reacts to inflammation by calling on all the cells in the body we call cytokines. And when you are stressed, your body also secretes some hormones called epinephrine. And those things affect the vessels, it causes the vessel to vasoconstrict. What does those vessels carry? They carry blood. And what does blood carry? Blood carry oxygen. And where does those oxygen go? It goes into your tissue to help your cells and the tissue to perform the functions that we call life. That might be contraction of the muscle, you move, that might be the blood flow to the brain, then you are able to think, that might be to the lungs, you breathe. So inflammation leads to a recruitment of cytokines, and the cytokines have adverse effect on your body, leading to disease. So that is why when we talk about the social injustice, the stress, all these things come together to create insult by creating inflammation. So when we talk about the non-medical issues that contribute, I will call the social determinant of health. They're not just words, even though they are words, but these are words that have consequence on our body because they create this inflammation that lead to recruitment of cytokines. And these cytokines, like during COVID, you heard about the cytokines a lot. It's still the same process of inflammation. Next. So the healthcare disparity, as we talk about, and we now switch to what we call the population-based healthcare system, where we bunch people together in race, gender, education, income, social class, and a lot of stuff. So the racial ethnicity and gender, and the more education you have and the more income, all those are what we call the population. You can define population anywhere you want to, but those are how we usually divide into. So all those create their own disparity. If you have money, you don't have to worry about insurance. You can pay for anything, right? Now, for people that have to depend on insurance, Medicare, and all those things, then there's a lot of issues with these things that help to create stress. Again, what does stress lead to? What does stress lead to? What does inflammation lead to? I want to empower you so that you know the right terminology to use so that when you heard about the social determinants of health, you know it's not just a word, that it affects the way things are in life. Next slide, please. Now, we get into the cardiovascular disease. American Heart Association, the leading body that gave us all these statistics, tell us that the Black, Hispanic, the American Indians, and all the ethnic minorities has disproportionate incidence and prevalence of heart disease. So, example, Black adults experience higher burden of cardiovascular risk, such as hypertension, obesity, and more than twice likely to die of cardiovascular disease relative to other groups. Now, the risk factor for heart disease come from several factors, including genetics, physical activity. So why did I bring genetics here? What we see in the hospital, we see Black people come into hospital with congestive heart failure without history of having heart attack. Okay? The white patient will come into hospital with congestive heart failure with a previous heart attack. So why is that the case? Then there was a big study that was done at the VA hospital all over the country. Then they find what we call this concept of genetic polymorphism. That means that the blood vessels of Black people lack the natural, what we call nitrous oxide. Nitrous oxide are chemicals that allow the vessel to dilate. So we tend, and the reason that study was very important is that it changed the way we prescribe high blood pressure medicine. Because right now when patients come to the hospital and look at their medicine, if the medicine do not include a vasodilator, that doctor is not taking good care of you. Okay? So when you have a high blood pressure, you have to know what your doctor prescribes for. And the medicine must include a class of drug called vasodilator. And that one of them is what we call hydralazine. If you don't take hydralazine, that your doctor is not prescribing you the right medicine. It has to be one of them. If your medicine does not include nitrate or indole, then it's not giving you the right medicine. If you are an African American, because those are the medicine that allow our own vessel to have that nitrous oxide that is a vasodilator, thereby allowing your vessel to dilate to carry blood into the organ system, so that your heart does not work so hard to create you to have congestive heart failure. The other thing is, so that was the importance of that study, which is something that is in the genes. What are the other things? Obesity. What is that? There's something we call a body mass index, and the number is 26. Okay? Again, if your body mass index is more than 26, studies have shown that when you are morbidly obese, again, you create a state of inflammation to your body. What does inflammation does to your body? It recruits cytokines, what we call interleukins, tumor necrosis factor. It recruits, then your body secretes norepinephrine, all those things. It helps to vasoconstrict. And the vessel carry blood. The heart is a pump. So it pumps the blood into the vessel that carried into the organs to provide oxygen to perform the function. So if you are obese, and if you are more likely to die of cardiovascular disease. What does obesity also do? Obesity also creates insulin insensitivity. Studies have shown that the fat block the insulin receptors. Okay. So that is why if your body mass index is more than 26, you are more likely to develop diabetes, what we call insulin sensitivity. Okay. So it is therefore helpful for you to keep your body weight down. Also, what we've also found that there's a new medicine that we have now called Ozempic. If you develop diabetes and your body mass index is more than 26, you should ask your doctor to prescribe Ozempic for you, because the study have shown that if you take Ozempic, you could lose 10% of your body weight. And when you lose that, your body has tendency to use insulin better. But the problem that we run into with Ozempic is that if I prescribe you Ozempic, your insurance is not going to pay for it. Your insurance is going to tell me to start you with something cheaper, which I know is not going to help you. So that is why there's so many things. I came back from Washington, D.C. yesterday, where we had to go to lobby the lawmakers to let insurance allow us to prescribe what we feel is helpful to our patients. Next slide, please. Again, hypertension. why do we develop high blood pressure so at such an early age? A lot of young people develop high blood pressure at a young age. You tell them to take medicine, they have no concept what you're talking about. And they let their blood pressure go so high, and they end up in the hospital with stroke. Again, because of we still believe that the concept of genetic polymorphism has to be taken seriously, so that when you go to your doctor, your doctor has to put you on the right medicine to help your blood pressure. The other thing, then we also talk about the social determinant of health. Social determinants of health are things that create stress for us. Some people can't even afford anything. You can't afford, I mean, you're driving in a car, police chase you, you're stressed out, and all those things. So there is a lot of things that contribute to us being always at the state of vigilance. Then the vigilance creates stress. What does stress do to your body? It creates inflammation. And what does this inflammation do? Cytokines. And what does cytokines do? It all does vasoconstriction. Thank you very much. Next slide. Okay, look at this study, 2021, and this was a 5-year study. This was done by the American Heart Association. You can read it for yourself, that they did a comparable study. Say, compare with white American, black American had higher hypertension prevalence. Black Americans have the highest prevalence of any race and ethnicity. Although they are aware of this, but they still have the significant lower control. Why? Because one, we prescribe something for you, insurance is not going to pay for it, and you forget about it. When you forget about the blood pressure is not going away. You still have it, and you end up in the hospital with what? Heart attack or stroke. So the other thing that we want to talk to you about is smoking. Now they're having not even smoking, vaping, chewing tobacco. These things are not good for you. What does nicotine do for your body? Who can tell me what nicotine does? How? Nicotine is the most potent vasoconstrictor. Remember that we don't have nitrous oxide enough to even start with. Now you take nicotine on this, your vessel will become like a wound. No matter how much amount of blood is trying to pump. And remember that the heart is a muscle. When the heart continues to work hard trying to pump the blood, it becomes so large that it becomes useless. Then you go into what we call congestive heart failure. So therefore, the downstream consequences of inadequate blood pressure control among Black Americans are very, very substantial. So it leads to quadruple your mortality risk compared to any other people. Next slide, please. Other risk factor for cardiovascular disease other than high blood pressure, obesity, diabetes, hypercholesterol, sickle cell, smoking, increased sodium intake. When we tell you don't eat too much salt. Do you know why? Why do we take you too much salt? We usually try to drive this point home for those of us who believe in the Bible. Is there anyone that has a Bible here? Do you have a Bible here? Can you read Ruth 1, verse 16 for me, please? Ruth 1, verse 16.
Yes, it says, don't ask me to leave you and turn back. Wherever you go, I will go. Wherever you live, I will live. Your people will be my people, and your God will be my God.
Okay, stop there. This is what we always said. Wherever salt goes, what follows? Water. Water follows salt. And what does salt water do? They expand the plasma volume. Okay? So we tell you, don't eat salt. You eat too much salt, it goes, water follows salt. It expands the plasma volume. When that happens, if you have a weak heart, your heart cannot pump those volumes, and those volumes seep into your lungs. What you cannot breathe. You have a pulmonary edema. It seeps into your legs. It seeps into everywhere. So what we tell you, don't eat too much salt because of this. Salt, water follows salt. So like the root follow. Now we also talk about stress. Next. Next, please. Next slide. Okay. Go to the next one, please. Next slide, please. Okay, we were in Washington, D.C. this week, trying to talk to the senators on how to help us to take care of our patients. So, next one, please. So, we were there to talk about reforming healthcare. There's a law now is coming around calling the state therapy protocol. We asked them to expand access to health, and we asked them to make sure that when they vote on the what they call the debt ceiling, that they make a good decision. Next one, please. So therefore, this is if you don't know anything else, if you don't take anything else here, I want you to take this. If you have diabetes, next time you go to your doctor, I want you to ask your doctor, what is your hemoglobin A1C? All right? Next time you go to your doctor, you have diabetes, say, doctor, I want to know my hemoglobin A1C. I want to know my total cholesterol. I want to know my HDL cholesterol and my triglycerides. This is to empower you, because when patients come to this doctor or hospital where they ask them, what's your hemoglobin A1C? They say, what is that? Your hemoglobin A1C predicts when you go to develop cataract, when you go to develop heart disease, when you go to develop a limb amputation. If you have heart disease, next time you go to your doctor, same question. Doctor, what is my LDL cholesterol? If your body mass index is more than 26, tell your doctor how can you stop smoking, what is a better way to decrease your stress, and ask your doctor, please, can you prescribe me Olympic? All right? Now, if you have hypertension and your doctor puts you on a medicine, I want you to know the names of those medicines. Ask your doctor, am I taking a beta blocker? And one of them is called Lopressor. Or am I taking ACE inhibitor, such as lisinopril? Or am I taking a vasodilator, such as hydralazine or Imdor? Or am I taking calcium channel blocker, such as Norvas or Cardizem? Or am I taking diuretics, such as hydrochlorothiazide or Lasix? If your doctor don't put you on any of these medicine, you have to change. And you have to know the names of the medicine you're taking. Huh? These are, you have to take, they can combine. We can combine it, or we start with one, we might add another one, or we might combine based on what we want to achieve for you. You know, but you have to, at one point, you should be on all of them, actually. Yeah. These are what studies have shown would prevent you from having heart attack. And if your doctor puts you on the right medicine, a beta blocker, ACE inhibitor, a vasodilator, calcium channel blocker, or diuretic. You have to know all these things.
Isn't there some type of way that we can figure out our BMI on our own according to weight? And
yes.
Thank you.
Yes. Is your weight in kg, weight in kilogram, divided by your height. That's your BMI. So that all these things that we're talking about, science and strength, they are not magic, these are nothing but science. So you have to take care of your body with science. You know that answer. Do you understand? Yes. Next time you go to your doctor, you know what to ask, right?
Thank you so much. We got it. We know what to ask. You were amazing. You were amazing, Dr. Udoa. Thank you so much. Thank you so much. All right, we've got another sponsor video right quick. I've got a pair of gift certificates to the Brooklyn Banquet and Conference Center. Regina, are you praising? You got your hand up. Was that a praise? All right, have mercy. All right, our video.
Did you know about our Bright Start maternity support program? At First Choice by Select Health, we have regional baby showers with car seats, diaper bags, and more for qualifying members, a new electric breast pump, and home-delivered meals for new moms enrolled in Bright Start. Moms can get gift cards for healthy behaviors, too, and tips and reminders over text to help ensure safe full-term pregnancies and healthy babies. Make us your first choice today. To learn more, visit selecthealthofsc.com.
We want to thank Healthy Choice, all of our sponsors, Select Health, Grail, also Dr. Moses Adua, also DHEC, South Carolina Commission for Minority Affairs. Don't forget that their gala is coming up June 26th. 29, thank you, featuring Bakari Sellers. It is a scholarship banquet, so please go to the South Carolina Commission for Minority Affairs website for more information and for tickets. Right now, I've got a pair of gift certificates to lunch here at the Brooklyn Banquet and Conference Center. Can anyone tell me where Dr. Moses Uda practices at? He is the... Hold on, calm down. Calm down. All right. I heard nothing anybody said. Somebody said the wrong thing. Okay. Anthony said somebody said Prisma Health. He's not at Prisma.
Oh, he's not?
No, that's not what this says. He is clinical assistant professor of internal medicine at. Oh, come on. You said it. Did Regina say it? Come on, Regina. Do you want to? Come on, girl. Come on. I'm trying to give you the gift certificate. Congratulations to Regina. She looked like she was going to beat me up. I said it. Thank you. I can't fight today. Not today. All right. Our keynote is from Prisma Health. To introduce the keynote, please welcome the president of Baptist Hospital, Anthony Jackson.
All right. Good afternoon. Okay. I am very good at making sure I follow instructions, so I know what my role is right now. This is the first time I've ever been introduced to make an introduction, so I'm excited about that. Today, again, my name is Anthony Jackson, and I'm president of Baptist Hospital, and Prisma Health is proud to support the South Carolina Legislative Black Caucus in its efforts to bring together health organizations, professionals, and civic leaders across the state to make a positive impact in the communities that we serve. At Prisma Health, our purpose is at the core of every single thing that we do. We believe in inspiring health, we want to serve with compassion, and we want to make sure that at every opportunity that we demonstrate the fact that we want to be the difference. Our team members bring this purpose to life every day through every interaction as we care for patients. We also strive to bring our purpose to life within the communities we call home. Supporting events like the Minority Health Summit helps to do just that by addressing social determinants of health to promote health equity. As you will hear in just a moment, Prisma Health is here for South Carolina, and we're more committed than ever to creating a better state of health for the communities that we serve. At this time, it's my distinct honor to introduce Mr. Clarence Civilian, Executive Vice President and Chief Operating Officer of Prisma Health, as today's keynote speaker. Thank you.
Good afternoon. I'm Clarence Civilian, Executive Vice President and Chief Operating Officer of Prisma Health. First off, I apologize for not being there. I was really looking forward to it. Unfortunately, an unexpected ankle injury has kept me from being in person with you today. On behalf of Prisma Health's nearly 30,000 team members, it is our privilege to take part once again in the South Carolina Legislative Black Caucus Minority Health Summit. I appreciate the opportunity to speak with you about a variety of important topics impacting our state's minority communities. As the state's largest healthcare company, Prisma Health provides care to South Carolinians across 305 physician practice sites and 18 acute care and specialty hospitals. The healthcare landscape is rapidly evolving, and Prisma Health has made great strides to transform our organization to meet the changing needs of our patients and communities in South Carolina. Last year, our state's national healthcare ranking improved from 45 to 41, which is evidence that we are moving the needle in health outcomes despite the current challenges healthcare organizations are facing across the country with workforce shortages, supply chain disruptions, and many more. Research shows that health outcomes are often worse for racial or ethnic minorities, women, people living in rural communities, people with disabilities, and other historically marginalized groups. Although healthcare equity is often viewed through a social justice lens, we understand it to be first and foremost a quality of care problem. Prisma Health is committed to advancing health equity and ensuring the quality of equitable health care is delivered to everyone. Health equity is achieved when everyone has an opportunity to receive the highest quality care regardless of their income, race, ethnicity, language preference, gender, or age. To demonstrate our commitment, Prisma Health has signed and endorsed the American Hospital Association Equity of Care Pledge. This important pledge builds on the national call to action to eliminate preventable racial and ethnic health care disparities and address gaps in care. We recognize that achieving health equity requires ongoing efforts to improve quality, safety, and the care experience for all patients. To achieve transformational and sustainable improvement for our patients, we must first be aware of their health-related social needs, such as access to transportation, housing or food insecurities, difficulty paying for prescriptions or medical bills, and lack of education. These barriers can create disparities in life expectancy, access to services and treatments, overall level of medical care, and other important quality outcomes. One of the ways we are achieving this is by collecting and analyzing socio-demographic data to identify at-risk populations and what obstacles those patients face in accessing care. Once those needs are identified, our goal is to connect the patients with the existing services, such as our diabetes disease prevention and management program. Doing so not only helps to address healthcare disparities directly, but also informs of gaps in those services and support that are available to our patients. As the state's largest nonprofit healthcare provider, Prisma Health was formed to help improve the state of health in South Carolina. We have a unique opportunity to work collaboratively with civic, business, legislative, and community partners to improve health outcomes. Our partnership with the Columbia Housing Authority is an example of this collaboration. Residents of Oak Reed, High Rise, and Arrington Manor are now connected to resources that ensure care is delivered in the right setting through care plan design, implementation, and monitoring. This approach leads to improved health outcomes and reduces overall cost of care. Another example of how we are working to eliminate barriers is through Prisma Health Midland's Healthy Start. This program helps ensure that pregnant women have positive birth outcomes. Maternal and infant outcomes are improved by prenatal care that begins early, is risk appropriate, ongoing, and comprehensive. Midland's Healthy Start provides education and support through home visiting, virtual groups, and classes, and connecting pregnant women with health and social services. Our work is far from complete though. We look forward to continuing to grow our partnerships with like-minded community benefit organizations, legislative representatives, neighborhood associations, faith communities, schools, and other community groups. Together, we can make a positive difference in the lives of those that we serve. Thank you, thank you, thank you for your continued advocacy to improve health outcomes for the minority communities of South Carolina. Together, we can be the difference.
All right, thank you so much to Clarence Avillion, Executive Vice President and Chief Operating Officer at Prisma Health. Thank you so much, Prisma Health, and Anthony for your support of the South Carolina Legislative Black Caucus. I have 2 free 10-point health screenings at Restore Chiropractic. Does anyone need a 10-point health screening for chiropractor? I do have Shaniqua Edie. Is Shaniqua Edie still here? All right, you've got one. It's one of our door prizes. And actually, Benita Clemens was the next person on my list again. All right, ladies. All right, I've got one more trivia question for you for you're welcome, Benita, thank you, for the final pair of gift certificates to eat lunch here at the Brooklyn Banquet and Conference Center. Does anyone know who the current chair of the South Carolina Legislative Black Caucus is? You are correct. Oh, okay. Congratulations. So please welcome the current chair of the South Carolina Legislative Black Caucus, Dr. Ivory Thigpen.
Come on, not just a hand for me. Give yourselves a round of applause. Let me begin by thanking our wonderful host. Doesn't Trey Taylor always do a wonderful job? She is the best mistress of ceremony that is in Columbia, probably the state of South Carolina, and even the Southeast, if not the nation. Definitely want to thank all of our sponsors. Want to thank Healthy Blue. Want to thank Select Health, Dr. Moses Udo. Want to thank Grail as well as Prisma. Without each and every one of you working with us to address health concerns, particularly in the Black and minority communities, we would not be able to raise awareness, to promote education, to help individuals not only with their own personal health and wellness, but even with their loved ones and the ones that they care for. Truly, it takes not only your family, but your community to address these issues and the disparities that exist. We know that as the South Carolina Legislative Black Caucus, health is an economic issue for individuals who have illnesses or disease, or ones who fall statistically in these disparities. Oftentimes, not only do these illnesses invade their bodies, it invades their bank accounts as well. I can tell stories of even as my youngest child received a trauma to his head, we received a bill of over $40,000. And I like to think I make decent money, but not that decent. And so as we combat and continue to not only educate, one of the things that I thought was very important about this health summit is that we also talk not only about care and the delivery of care, but also prevention. I'm a firm believer that an ounce of prevention is worth a pound of cure. The more we can get on the front end of educating and bringing awareness and allowing individuals to live healthy lifestyles, the better it is on the back end. And so again, we want to thank you for being here. I apologize for coming late. My youngest daughter graduates from high school this year. So she's a high flyer, both athletically and academically. She's in the top 10. I can keep on bragging, but I won't, because I know that's not what y'all came here for. She wants to be a pediatric surgeon, right? And so she's well on her way. She's received scholarship to Hampton University. And no doubt will come back to the state of South Carolina and may well join one of these health systems, so you can start the recruitment now. Truly, my heart was here, even though my presence was not initially. Again, I want to recognize and thank our director, our executive director, Devin Owens, who does a wonderful job of putting these events together. Last but not least, I want to recognize all of our representatives and senators that make up the South Carolina Legislative Black Caucus, and whether they were here in person presenting or joined us via website and virtually. Again, their presence and their participation in the caucus is what makes us the 50-year institution that we are. For this is the year that the South Carolina Legislative Black Caucus celebrates 50 years of education, advocacy, and legislating. And we're fighting for black and minority communities to ensure that South Carolina becomes the best South Carolina it can be. So with that being said, without further ado, we're going to close us out unless there are any other announcements that need to be made. Yes, sir.
The young lady was asking a few minutes ago about we're doing research. When do we get the results? Okay, I want you to Google this word, implementation scientist. That is a new science that's been out there less than 10 years. Implementation science. I do work with MUSC and USC. They reached out to me from Wake Forest, so that's what's going on. It's less than 10 years old. Go research that right there, implementation scientist. I'll give you some information on me. You can reach out to me, but that's what you want to do. The results are there. Now, moving from practice to implementation, 17 years. We got to shorten that. That's what's happening, okay? So we got to do that. We got to become engaged. The community must become engaged. Churches must become engaged, more engaged.
All right, let's give him a hand. And again, from photography to audiovisual to all those who play a part, I know we have leadership from our community and statewide and individuals and officials from all over. Again, I see our president of the NAACP. Want to thank you for being here. With that, without further ado, Ms. Brenda Murphy, thank you so much. You can stand again. Come on, let's give her a round of applause. Without further ado, this completes our health summit. Thank you again for coming out.